image, this is a prostate CT and a prostate MRI. These are linked and registered, so they're volumetrically aligned. And you can see where we put fiducial markers. These are gold seeds, so they're bright on a CT scan because they're dense, and they're dark on the MRI scan because they create what's called a susceptibility artifact, and it creates like a T2 hypointense signal. And we can put a structure on so there's a little purple circle around each one, and we can get the two images lined up using those fiducial markers as the criteria for registration. And then the final thing we often do is image fusion, which sometimes registration and fusion are kind of used interchangeably, but I guess in my mind, fusion to me kind of implies taking different image types and overlaying them so you create a new separate type of image. So probably the most common example is the FDG PET CT, where you get a CT scan and then you get the PET scan and they're fused, and you can take or use one or the other image separately, or you can take the fused image as a separate data set. So in this case, this will be a prostate, this is the CT, this is the PET signal, and this is the fused PET CT image. And you can actually mix and match all of these different ways of arranging images. So for instance, you could take a CT from like 3 months ago, and you could take the PET from 3 months ago, and you could fuse the PET to a CT, fuse the PET to a CT that you have from today. So you can sort of mix and match the different study sets depending on how you want to deal with it. A common example of where we might do that clinically is if a patient has, say, a lymphoma, like a diffuse large B-cell lymphoma, they will often get an initial PET scan for staging, so maybe the lymph nodes are very large and very bright on PET. They'll probably get chemo for a couple months, so maybe like R-CHOP chemotherapy. They'll probably get another PET after chemo. At that point, the PET will probably show that the lymph nodes have shrunk and the FDG uptake on the PET is much less. If we are asked to do radiation on the remaining lymph nodes, so we might call that consolidative radiation, what I'll often do when planning is we'll take our CT that we're using for planning, the current CT, but I'll go back in time and get the original CT from before chemo, register the current CT to the original pre-chemo CT, and then register the PET signal to our current CT. So we're kind of bringing the PET forward, but it's helpful to have the registration on the CT because it's easier to register CTs than it is to register a different CT to an old PET, for instance. So it's kind of like dominoes in a sense. But that's helpful because we need to target the original extent of the disease before chemo, not just the little remainder after chemo. So as I was kind of explaining, registration is very helpful. Also, the reason I'm making such a big deal out of this is, I mean, it's not like you might be sitting there thinking, okay, so get the images lined up, what's the big deal? But when I was in training, the registration software was very inefficient. And so what we would do is our planning system, for instance, would have a registration module, I guess you could call it, and it's basically just an image space. And when you want to register two images, it would just put the DICOM data in the image space, and then it would pretty much just make you do it manually. There was some rudimentary registration algorithms, but it wasn't very good. And so you as the user would have to take the CT and the PET and try and get them lined up just visually. But so you have to do like orthogonal translations and rotations. And every time you make one motion, one part of the image might line up, but then the other part might be out of range. And so even something simple like trying to register an MRI to a CT scan of the head or a PET to a CT, it could legitimately take 20 or 30 minutes just to do one of those registrations manually. And then if you want to go through and do more, like you have 3 MRI sequences, you got to do those separately. So this kind of stuff could take hours, but now with software, like we use a software program called MIM, the registration software can take almost all these different types of images and modalities, and it can get them pretty well registered within like seconds type of thing. So it saves a lot of time. And so it allows superposition of all these different imaging. I mean, we have a lot of patients that have a CT without contrast, CT with contrast, MRI, PET CT. A lot of times when planning, I'll try and get all these images that we have access to registered so that they're all anatomically oriented together. Another thing that helps with is, you've probably noticed, due to geography, insurance, whatever the case may be, we have a lot of patients that get images all over the place. It might be their insurance, the copay is cheaper to go to DIS than our scanner. We do our planning scan, but they've got an MRI, or they went to MD Anderson for a second opinion, they got an MRI over there. So we can't like supervise how those images are done, and we don't know exactly how they're oriented, but when we get the DICOM data and the image files, we can use our software to get everything kind of oriented in a similar position for comparison purposes or treatment planning purposes. So here's an example of where this is very helpful. So this is kind of just to display. So I deal with a lot of gynecologic cancers in my practice, and so cervical cancer is a common scenario where image registration is very helpful. So with cervical cancer at initial staging, we usually will get a PET scan and often an MRI and a CT with contrast. Now here's a particular case that I run into every once in a while, but this is a case of a cervical cancer with what we would call submucosal vaginal extension. So the tumor is in the cervix, but then it's kind of creeping along the vaginal surface, but under the mucosal surface, meaning like if I were to look with a speculum and do an exam, I couldn't see that part. It's like it's subterranean. But we can see it on imaging, and co-registration is very helpful. So here's an example of this kind of scenario. So this is our MIM software, and we've got the CT non-contrast, PET CT, CT contrast, and then the CTs are registered. And these are axial, sagittal, and coronal slices, so this can display all this imaging in one pane. And this is at the level of the upper vaginal canal before the cervical tumor. So the cervical tumor is this right here. This is sagittal looking at from the side. It's actually blocking the uterine canal, causing fluid to build up, so we call that hydrocolpos. But you can kind of see this little tail of uptake going down the vaginal canal. But when I look on exam, I can't see that because it's submucosal. It's probably a form of angiolymphatic spread. So at the level of about here in axial section, this whole thing is circumferentially metabolically active. And you can see it takes up contrast, and the whole thickness of the vaginal canal is much thicker than average. Again, this is not something I could see on exam, but we see it on imaging. So this is very helpful to be able to get all these images registered to kind of make sure we know what we're seeing. And then what will typically happen with cervical cancers, we'll do initial treatment with external beam radiation for about 5 weeks, and they usually get chemo with it. And that normally causes a pretty substantial response of the tumor, and sometimes you can barely see anything left behind. But after the external beam radiation, we need to do what we call brachytherapy or internal radiation. We have to put a device in, or an implant, or an applicator, different names for the same thing. But that allows us to give a higher amount of dose to the interior of the tumor so that we can make sure we get a very large biological equivalent dose to the tumor. But by putting it internally, we can minimize the exposure to the normal tissues. And so in this kind of scenario, so what we're doing here is this is after external beam radiation, and the patient would have had a pretty good response. So now we're using an applicator called a tandem and multi-channel cylinder. So a tandem's kind of like this curved stick thing here, and the cylinder is kind of this little popsicle shaped thing here. And so this is a scan that we do immediately after implanting the device in our procedure room. And so in axial, this is the same level that we were looking at on the previous slide, but what the concern is I need to give dose to that area that it was subcutaneous or submucosally involving the upper vaginal canal. So we know we need to treat this whole tandem up here, but the question is how much of this cylinder do we need to load with dose to make sure we include all that disease extent, even though I could never see any of it at any point, but we saw it on the imaging. And so what we can do with the software is immediately after we get this scan, the patient's now waiting in the procedure room with this device in place, waiting for us to get our plan done. So I go and pull up MIM, register the prior images to this CT. Now it's not gonna be perfect because there's an applicator here and there wasn't on initial staging, but you can get it pretty close. It kind of uses the bone. But for the question I'm asking, it's still pretty helpful because I'm looking for the extent of disease so I know how much of the cylinder part that I need to load to include what was the submucosal extension. And so you can kind of, they're pretty faint, but you can kind of see the dose lines going around the tandem, and they extend down partway along the cylinder. And this particular type of applicator is pretty well suited for that scenario. Usually we use a different applicator, something called either a tandem and ring or tandem and ovoid, but those don't allow as thorough of vaginal coverage. So this is just an example. And then another thing is, like I was mentioning before, because the patient is waiting on us, it's not great for me to just sit around for hours dealing with registration like I had to do a decade ago. But the fact that our software can do this in a couple seconds is very helpful. So I can get the original CT, the PET CT, the MRI, I can get all those lined up within minutes to kind of help with this planning. So here's another similar type of example, another gynecologic case. What I'm trying to display here is occasionally we'll see what we call a vaginal cuff tumor. It's usually a squamous cell carcinoma after a prior hysterectomy that might have been done years ago for benign purposes. But these are a little bit challenging. They're usually not surgically resectable. And so this is an initial staging PET CT. And so we see the PET signal in the bladder, which is normal because the urinary system collects the dye. So we would typically see this bright signal in the bladder. And we see the tumor here, which is also bright on PET. But you can kind of tell, because it's right next to the bladder, we get this signal that kind of blends together. So if I was just looking at the PET, I can't necessarily tell you exactly where the tumor ends and the bladder begins because it's all got the FDG signal. But if we can register a different anatomic imaging modality like an MRI scan, then this makes it a little more clear. And the reason this is helpful is we will often design an external beam radiation plan, but I might want to, so the plan might include a large area of the pelvis, but I might want to boost the tumor specifically with what we call an SIB, or a little bit extra dose, I guess you could say. But I only want to boost the tumor. I don't just want to, if I can avoid it, I don't just want to boost like half the bladder because I can't tell the difference. But here, especially on T2 MRI, you see a nice bright fat plane between the anterior aspect of the tumor and the posterior aspect of the bladder. So that makes it much more accurate. So this is just an example. Registration helps getting different imaging modalities in alignment so that you can make decisions or do planning based on the particular type of data that that imaging modality can provide. And then so what we would typically do here is similar to the last case where we would do external beam radiation for about 5 weeks. And then again, we would do brachytherapy or an implant. And so what this is gonna look like, in this case, we're just using, these are just additional examples of the registration. So here we have the primary CT. This is a little fiducial that I put in the tumor. This is the PET CT, and this is the MRI. Here again, the fiducial is a little bit T2 hypointense on MRI, and it's dense on CT because it's metal, it's gold. And then so once we're done with the external beam radiation, we have to do the implant, the brachytherapy. In this case, it's just the cylinder. There's nowhere for the tandem to go because they had a hysterectomy. But the multi-channel cylinder lets us load different aspects of the cylinder with different weights. And so what I'm trying to do is, what you can kind of see here is this is the pre-treatment imaging that we saw before. This is the post-external beam MRI. So the lesion largely disappeared. That's a good response. But we know that with the brachytherapy, I need to treat this whole area, but I need to treat this with a higher dose because that's the highest risk location. So the patient's left vaginal apex needs a higher dose than the right side because that's where the tumor was. And so when we do the implant, again, this is just kind of trying to highlight the dose line, where on the patient's right side, the dose line just hugs the surface cylinder, but on the left side, where it's higher risk, the dose line is a little bit deeper into the tissue because we need a little bit better coverage there. But in order to make sure that I have the appropriate length of cylinder, again, that's where it's helpful to get these images all registered together so that I know how far along to do that boosting. And also, again, it's helpful to be able to get these images registered quickly because the patient is just sitting there with the device and waiting for us to do the plan. And then here's another example. So in the previous example, it was kind of showing how anatomic imaging can help clarify if metabolic imaging is giving us a little bit of confusion in the sense that it's right next to the bladder. So here's kind of an opposite scenario where the metabolic imaging can be helpful when the anatomic imaging is not so clear. So in this case, here's a patient who had EGFR mutant pulmonary adenocarcinoma, and they were on Tagrisso, a targeted drug, for about 4 years with no progression. and they developed a solitary liver metastasis. And so the medical oncologists, I mean, they had no other disease, so they're kind of saying, well, this Tagrisso is working pretty well, so we don't want to just switch drugs. If you could just treat this one thing, we could just stay on the medication otherwise. So we targeted this lesion, we performed SBRT, so that's just kind of showing the dose lines there. But then about a year later, what we have is the patient is sent back with a new lesion in the liver, again solitary, so they've got this kind of indolent oligometastatic disease profile. And so when we get the PETs, so this is gonna be PET CT fusion and co-registration with 2 different PET CTs. So this is the original, we treated this. This is the new PET a year later. These are now registered as best we can. They're fused images and they're linked, so we're doing all that. But what the PET CT is showing is that what we targeted before is no longer metabolically active. So you got a bright FDG signal here. Now it's just kind of normal liver tissue density or intensity. But we have this new lesion, which is just immediately superior to the original. So they're kind of stacked on top of each other like snowballs. And so what would be helpful is they again want us to treat this new lesion because I mean everything else is going pretty well. But when I'm doing planning, I want to make sure we're targeting what is actually active disease, not what's like a prior remnant. And so when we do image registration, I can kind of show you what this looks like. But typically in the liver, after radiation, you will get a permanent hypointensity or hypodensity. So this is the current previously treated lesion that responded. There's no FDG uptake, but there's this dark spot on the liver, and that's just going to be there forever. Now, this is the new lesion on the current scan. This is FDG avid, and there's also a dark spot that's just immediately superior to the old dark spot. So if I only had the CTs to work with, I wouldn't necessarily be able to tell exactly where the new dark spot begins and the old dark spot ends. But with the metabolic imaging, it makes it much more clear. So that's helpful for treatment planning. Another example that we often run into is managing brain metastases and brain imaging. So especially nowadays, we have patients that will do Gamma Knife Icon or stereotactic radiosurgery for brain metastases. Some people have done this procedure dozens of times over many years. And so we have like a collection of their MRI scans over many years. We might have 10, 20 MRI scans. And you would think it would be easy, that the brain isn't that big of an organ, but as you see, it's very complex, all these little sulci and gyri, and any little misalignment between the rotation of 2 images can be kind of an illusion to trick you if you know what you've treated or not. And so what we can do is, if we need to, we can take prior images and their structure. So this is a structure that we created on a prior image that we used to target. We can use those in the future if we need to. So here's an example. This is a patient with oligometastatic breast cancer that had a couple of brain metastases. This is one of them in the left frontal lobe that we treated. And then again, about a year later, she came back to clinic. Her insurance had changed, so she was getting MRIs at a different location for insurance purposes. So she came into clinic with an MRI that says there's a new left frontal lesion. So now I have her disc in clinic and I have our old imaging, but I would like to figure out if this is what we've treated before, maybe a reaction to the treatment, or if it's actually something new. And they're close enough that if I were to just kind of eyeball it, I'm not 100% sure if this is the same lesion or if it actually is a new lesion. So what we want to do is get these images co-registered. So these are about a year apart. This is our image, and this is a new image she got from an outside center. So we're going to get those into our registration software. And once we get them registered, we can put the structure from the original scan, sort of like superimpose it on the new scan. So now what I can see is that the original lesion that we targeted a year ago, the structure, when that MRI was registered to our current MRI, the structure goes with the registration. And so now I can see this target from before is a little bit anterior and along the superior aspect of the new lesion. So this right here is the new lesion, and this is the plane, just the very superior aspect. So it's not the same lesion, it's a new lesion that does need to be treated. But that just kind of helps me quickly clarify that in clinic without having to go through a whole big process of trying to redo the whole Gamma Knife procedure without knowing until the day of that if it's the same or not. So switching gears a little bit, there's just a couple more topics and I'll try and go through these quickly. But in clinic now, at least in my practice, we're using a couple of AI tools. One is for what we call auto contouring, so generating structure sets on an automated basis. And then I use it for basically transcription and some risk analysis. This is really not specific to radiation oncology. I mean, anybody could do this, but I find it sometimes helpful in clinic. So on auto contouring, this has been something that's been desired for decades. When I was in residency, we had what we called Atlas-based auto contouring, but it wasn't very good. And so, but now with the newer tools, it's pretty accurate. And what I'm talking about is when we do treatment planning, we need to identify the targets, the tumor and all that, but we need to identify normal structures. So this is a cross-section of a young patient with a left lateral tongue squamous cell carcinoma that was resected, but there were high-risk features, and we need to do radiation post-operatively. So this is a CAT scan that we get for treatment planning. So I'm gonna need to contour the targets, but we've got a whole bunch of normal structures that need to be identified for the treatment planning system, like parotid salivary glands with the spinal cord, or the maxillary bone, or the mandibular ramus, so all these different things. So traditionally, somebody would have to manually do that. It might be a medical resident, it might be a dosimetrist, it might be me, but it takes a lot of time to do these. I mean, contouring a head and neck plan traditionally could take an hour at least. But we're now assisted with auto contouring, so we can send the data set that we want the contours on to a node that's got the capability to analyze the imaging and place what it believes to be the normal contours, and give it about 10 minutes and it comes back. Seems like magic on our end, but it comes back with all these contours. Now granted, you have to kind of check them and make sure it did it right, but for the most part it's pretty accurate. So now I don't have to do this, I don't have to do that, it's just all done on an automated basis, and I can kind of work on something else while it's percolating. So that can save a lot of time. We use that a lot for just routine treatment planning. Another thing that I've started using AI for, especially the LLMs, is risk assessment. So this same case that we just saw, I won't go through all the details that are here, but basically what I wanted to do is, normally in an oral cavity cancer, we will include what we call the bilateral submandibular lymph node drainage area, because it's a high-risk area for recurrence. But one downside to doing that is the submandibular glands are in that location, and so it kind of dries those up, and the patients are more susceptible to having like chronic dry mouth. So I just wanted to ask AI if it could do kind of like a little literature search to see what it thought the risk of a recurrence in the contralateral level 1B or submandibular drainage basin would be. My suspicion was no, that I could not do that, but I just wanted to check. So I gave it a prompt where I described all the features of the cancer in this particular case, and I just asked it if it could review any published studies that have similar types of cases, and if it could tell me what the risk level was. And I was thinking maybe if it said less than 5%, I might consider omitting that to try and save that salivary gland. It ended up it said drawing from multiple retrospective studies on oral cavity tongue squamous cell carcinoma with similar features, the estimated risk is 5 to 10%. And so base, and you put in the features of the patient you're trying to assess, and it will compare those features to its database. But I think the LLMs are probably pretty adept at doing the same thing, and it will just compare it to the literature that's available as opposed to one institution's database. And then one final thing I'll just mention, I'm sure a lot of people are aware of this, but there are now AI-based auto-transcription tools, so that I call it like a pocket scribe. So you could bring your phone with you with the app on. The phone will just record let's say you're doing a consult, it will record your conversation. It will transcribe that within like a minute afterwards. But then the other thing it does is it will organize it into a clinical note. So this is an example of a product that I use called Freed. So I'll just take my phone into a visit, it'll just catch whatever it can, and then it will basically format it into kind of a formal note with like an HPI, a summary of medical history, medications if it can catch them, family history. And it's pretty good at separating out what would be relevant versus what would be kind of chit-chat type of thing. So if the patient tells you about their golf game, it's not going to include that, but if they mention that their dad had prostate cancer, it will include that. So it's pretty effective, and it definitely improves speed in clinic, because then I can just let it do the note formatting and I can work on something else. So that's kind of the summary of some of the things I just wanted to discuss. And so thank you for attending, and thank you for listening. And I guess if there's time, I'd be happy to try and answer any questions if anybody had any. If not, then I'll get out of your way.
Thanks,
Yeah.
First of all, that's a bright laser pointer. Gee. Next would be Dr. Hari. Is it? So Dr. Hari is our nuclear oncologist at Mary Perkins, currently seeing his patients at our Gonzales location. He's spearheading all the efforts for our theranostics program, which is growing faster and faster. So, oh dang, I didn't bring my glasses. The targeted revolution, perfect. Oh, per Hari. So, is that what it is, more or less? I cannot read it. Sorry about that. There is a misprint? Dr. Hari?
I think so. All right. Hi, I'm Aditya Hari. I'm the nuclear medicine, nuclear oncology, and theranostics. I practice at Mary Bird Perkins Cancer Center, and I do research in Pennington Biomedical Research Center. Thank you so much for attending my talk. I have nothing relevant to disclose. Some of the topics that I wanted to cover in this talk are more focused on theranostic agents, what's approved and what's in the pipeline, and a few points about what we are doing in terms of workflow optimization, and technologically, what are the advancements out there. There has been a steady increase in theranostics market over the years. It started mostly around 2020. That's when Lutathera was first approved by FDA. It was approved in 2018, but all the institutions managed to bring it up and internalize within their own practice. And since then, it's been increasing and projected to increase exponentially for the next 10-15 years. There are multiple conferences that focus just on theranostics, starting with SNMMI, ICPO, targeted alpha therapies, ASTRO, and even today we have at least 3 theranostics talks happening in parallel, the first 2 in the genitourinary section. Radiopharmaceutical is a combination molecule. There is like a carrier molecule and there is a radionuclide that's attached to it. So this carrier molecule seeks wherever the target is, and it drags the radionuclide along with it, and that's what we do in nuclear medicine. We use radiopharmaceuticals. Can be used for diagnostic purpose or for a therapeutic purpose. And there are multiple AKAs for theranostics. People use radiotheranostics, targeted radionuclide therapy, molecular radiotherapy, etc. So conventionally, the cancer management is either through chemotherapy, surgery, or radiation therapy. And surgery and radiation therapy is mostly reserved for cancers that are localized, and you have some local regional spread, but chemotherapy is usually utilized when there is much more widespread disease. Theranostics, it offers a distinctive systemic therapy alternative to chemotherapy. So the theranostic agents also go wherever the chemotherapy goes, but instead of doing its pharmacological action, it does its radiation action. So theranostics is a combination of diagnostics and therapy. The receptor for the cancer would be the same. Ideally, the linker molecule should be the same, and only different should be the radionuclide that's involved. A weaker radionuclide is used for radioisotope is used for diagnostics, and a much stronger radioactivity is used for therapy. One of the oldest theranostic agents that people everywhere use is radioactive iodine. It's like a salt pill, but instead of sodium chloride, it's sodium iodide, and instead of normal iodine, it's radioactive iodine. And this has been used to diagnose and treat thyroid cancers. For example, you see here that I-123 sodium iodide is it's like just a gamma emitter, and it is used to see the extent of disease. For this patient, fortunately it's only reserved in the neck. While I-131, which is a beta emitter, it's used to kill the disease. And when the patient ingests I-131 sodium iodide, it also goes to wherever the disease is, but now it's trying to kill the cancer. This is the most recent classification of thyroid cancer given out by American Thyroid Association. It came last year, and it provided a clearer categorization of various differentiated thyroid carcinomas depending on their rates of recurrence. It's categorized into low, low intermediate, high intermediate, and high. And various characteristics of the cancer goes into these characterizations. For example, how big the tumor is, or if it is unilocal versus multifocal, or if there is lymph nodal spread, or if there is distant metastasis. And radioactive iodine therapy is suggested for intermediate and high, and of course for distant metastasis. It's not suggested for low, for diseases with a low rate of recurrence. A second good example is the use of bone scan for diagnosis of bony metastasis and radium therapy for treatment. It's not technically a theranostic agent because bone scan uses a different agent and radium-223 is a different agent, but more or less conceptually it's similar. ALSYNCA trial was the first clinical trial that showed benefit in survival metrics using radium-223, and this has been used since last 15 years. Radium is a calcium mimetic, so it goes wherever calcium goes. And bone scan is used to see the eligibility and the response estimation done with radium. So on here you see a baseline bone scan of a prostate cancer patient with so many bony metastases, widespread metastasis all over. And after 6 cycles of radium-223, you can see that all these hot spots, they are less intense. So there is decreased extent of bony metastasis altogether. The newer agents are engineered in a different way. So you have a cancer cell. It expresses a certain receptor. So the theranostic agent is designed in such a way that there is a agonist or an antagonist or an antibody to that receptor, which is here in green, and it's linked to a radioactive isotope. For example, here gallium-68 is a diagnostic isotope, and indium-111 is a Auger electron emitting theranostic isotope. So you can think it of like a train which carries so much coal, right? So the engine is the agonist or the antagonist, and the cars are filled with radiation. So the engine goes and stops wherever the train station is, so that the train station is the cancer molecule. So wherever the engine stops, the coal is delivered, the radiation is delivered. One of the first examples is gallium-68 dotatate. The dotatate is a somatostatin receptor 2 agonist, and the binding efficiency is super high, more than 95%. And it's used in neuroendocrine tumors. For example, here there is a patient with neuroendocrine tumor imaged with FDG PET versus gallium-68 dotatate PET. And when you compare both of them, you can see that the gallium-68 dotatate has much more contrast, have more signal to noise, and it can give a good extent, a true extent of the disease. FDA in 2018 has approved Lutathera, which is lutetium-177 dotatate, and this is for the treatment of metastatic gastrointestinal and pancreatic neuroendocrine tumors. So lutetium-177 is a beta-emitting radioisotope and also emits gamma. So the beauty of it is it can kill the cancer, and also you can use it to image where the lutetium-177 dotatate is going. On the left-hand side, you have a gallium-68 dotatate PET scan used for diagnosis of this patient, and also to see if the patient is eligible for this therapy. And you can see that with the lutetium-177 dotatate, it's given in 4 cycles. After the first cycle, when you image the same patient, anterior and posterior, you see that the lutetium-177 dotatate is going to the same places where the gallium-68 dotatate went. And at the end of 4th cycle, you can see that the intensity is decreased. So the cancer itself is reducing in size. You can see that in real time. And this is a different patient. In the baseline gallium-68 PET scan, there is widespread bony metastasis, widespread disease in the lymph nodes and in the liver. And after 4 cycles of Lutathera, a repeat PET scan is showing that most of the lesions have disappeared. Some of them have decreased in size. And NETTER-1 trial from 2017 showed that there is huge progression-free survival benefit with lutetium-177 dotatate. The other FDA-approved theranostic agent is PSMA. It's a membranous protein expressed in most of the prostate and also exocrine secreting cells, but it's upregulated in metastatic castration-resistant prostate cancer. So it's about 1,000 times more in castration-resistant prostate cancer, particularly when the patient has failed a couple of hormonal therapies and probably chemotherapy. And you can see here that when the tumor load is increasing, when the PSA is increasing, that's when the PSMA PET scan is much more beneficial. That's where its true value lies. And lutetium-177 PSMA is the theranostic counterpart for this, for the same target, and it's been shown to increase progression-free survival and overall survival for these patients. This is an example of a patient with widespread bony metastasis from prostate cancer. This is the baseline scan, and we had a repeat PET scan done at the end of 3rd cycle of Pluvicto and also at the end of 6th cycle of Pluvicto. You can see that some of the lesions, for example, the one on the top of the head and along the vertebrae, some of them have resolved and most of them have decreased in size. So it's much more easier to handle this disease right now. There is so much research happening in the world of theranostics. So it goes from detecting which specific receptor is most appropriate for imaging and treating a particular cancer. So what's the specific receptor? What's its agonist versus antagonist? or an antibody, what's a good linker molecule, and what is the good radioactive compound that goes along with it. Is it an beta therapy? It is a alpha emitting agent, or is it a Auger electron emitting agent, stuff like that. And here is a snapshot of all the new radiopharmaceutical trials out there. The outer circle is the chemotherapy, and the little donut, the inner circle is the radiopharmaceutical trials, the theranostic trials. And you can see that the green part, which is about 9%, that's those are the phase 3 trial, and it's mostly with PSMA and somatostatin analogs. And majority of the agents are still in the early phase clinical trials. And on the right side, you see the spread, the various targets that are being explored in relation to each cancer. And some of the actively pursued molecules are FAPI, which is fibroblast activated protein, or GRPR, gastrin-related peptide, and also some PAR. I'm going to give a couple of examples of what's coming down. FAPI, so think of this as spaghetti and meatballs. So cancer is comprised of cancer cells, which are the meatballs, and so much of stroma around it, which is the spaghetti around it. So the stroma is made of these fibroblasts. These are called cancer activated fibroblasts, and they are the essential ones which make up about 80% of the tumor environment. Only 20% is the cancer cells. FDG, PSMA, dotatate, all these are used to image the cancer cell, but FAPI is the one that's used to image the stroma that's supporting all these cancer cells. And they are much upregulated in not only in cancers, but also like autoimmune diseases or anything that causes some fibrosis. Here is an example of a female patient with sarcoma of the left breast. When you compare it with FDG, the FAPI on the right shows more number of lymph nodes, so it reveals the true extent of the disease. And probably the FDG, the sensitivity of the FDG is lower in places where the size matters. And on the right, you see a patient with esophageal cancer. The state of the art FDG is showing a avid circumferential tumor in the distal esophagus, while with FAPI, you also see the esophageal cancer, but then additionally you see this lymph node, and that that increases the staging of the disease. And the beauty of gallium-68 FAPI is you also have a theranostic component, which is lutetium-177 FAPI. And this is a patient with medullary thyroid carcinoma with widespread bony metastasis and osteolytic lesions all over. And when treated with 6 cycles of lutetium-177 FAPI, you see that the cancer is much more manageable and more, you get a better handle on the disease here. And here is another example of lutetium-177 FAPI. Oh, thank you so much. Sorry about that. Here is an example of lutetium-177 FAPI being used in iodine refractory thyroid cancers. For a very long time, we had the pleasure of treating thyroid cancers with iodine because they are essentially, they take iodine, they destroy themselves, and we are fine with that. But the real problem starts when they start to de-differentiate and become refractory to radioactive iodine. So here is an example of a patient with extensive disease within the neck with multiple lymph nodes that's highly FDG positive, so they are likely iodine negative. And with so many cycles of lutetium-177 FAPI, you can see that the extent of the disease is much decreased. And there is almost 90% decrease in circulating thyroglobulins. Another molecule that's out there about to come out is gastrin-releasing peptide receptor. It's also known as bombesin, and it's overly expressed in some of the most common cancers like breast, prostate, lung, and gastrointestinal tract. So GRPR is particularly useful in prostate cancer, which is PSMA negative, and low-grade prostate cancers. And also in breast cancers, which are much more, which do have more estrogen receptor positivity. And there is a trial that's happening elsewhere, and it's about to come to the US, where the bombesin receptor is being targeted using copper-64. That's the PET agent, and it has a theranostic component. It's copper-67. And these represent a true theranostic, an ideal theranostic agent, because the antagonist and the linker molecule would be the same. The only difference would be copper-64 versus copper-67. That's COMBAT trial, and I think it's still ongoing. And for example, here you see a prostate cancer patient who has completed all the 6 cycles of Pluvicto, and now you see that there is maybe one mildly avid upper abdominal node, but a concomitant imaging with copper-64 bombesin shows that there are multiple such nodes around the liver and the upper abdomen. So it's more used in PSMA negative disease. Now switching gears, along with the new availability of all these theranostic agents, there needs to be some changes in the referral patterns and the patient management. At Mary Bird Perkins, we have tumor boards for active discussion of patient management, where actual referrals happen from surgical oncologists, urologists, medical oncologists, endocrinologists, head and neck surgeons, dentists, and that's where we procure the patients from. And a core theranostic team comprises of a nuclear medicine physician, dedicated nurse navigators, and nuclear medicine technologists. So we are responsible for initial counseling the patient to discuss the pros and cons, and then insurance approvals, and then also measuring the efficacy versus toxicity of the theranostic agents. So during the actual delivery of the theranostic agent, we also require support from radiation safety, physics department, and also a dedicated clinical coordinator is needed, because there are so many appointments to keep track of and so many reminders for both the physicians and the patients and their families. So when the patient is initially referred for theranostics, we have an initial consultation. We discuss what it entails, what it takes to get through this treatment modality, the risks and benefits. The treating physician will independently review the imaging findings, the PET scan, to determine the eligibility, and then seek insurance approval. And during the treatment cycles, there should be post-therapy scanning, ideal for dosimetric analysis and also to assess for radiation safety. And long-term follow-up will be needed to assess for response and to also evaluate if there are any toxicities involved. So to be able to do this, we need access to a a hot lab for safe dispensing of radiopharmaceuticals, a SPECT-CT to be able to image right after, because all these theranostic agents, while they are able to effectively treat, like deliver killing dose of radiation to the cancer cells, they can also be used for concomitant imaging, and that's how it's designed. And this post-therapy SPECT-CT, there is a way to use it for dosimetry and assessing for effectiveness while the patient is receiving therapy. And also there needs to be a dedicated therapy room with access to a bathroom that's specifically reserved for radioactive patients. Here you can see me injecting Pluvicto, and this image was taken through a specialized radiation detector camera where we detect radioactivity and it's overlaid on the patient. So it's a way to say that the radioactivity is effectively in the systemic circulation. The other technological advancement is the use of post-therapy dosimetry. Lutetium-177 can also be imaged. So you can see that this is a post-therapy image done after the first cycle where there is no response yet. And the second set of images are the SPECT-CT done after 3 cycles of Pluvicto, so where you can expect to see some response. The software automatically contours whatever signal it finds apart from the normal organs, and you can see that there is so much decrease in the red when compared between cycle 1 and cycle 3. And research has shown that this decrease in the tumor volume it translates to survival probability. With the new software, the field is more moving towards adaptive dosimetry. For example, for now, we treat all the patients using empiric doses of radioactivity. And the field is more moving towards tailoring the dose to each and every patient. For example, the patient will receive an empiric dose of radioactivity the first time, and judging by how much the dosimetry wise, how much the organs are receiving, how much the cancer is receiving, and the patient's maximum tolerated dose, the radioactivity can be decreased or increased for appropriate patients. And this is the latest advancement in the era of artificial intelligence and computational nuclear oncology. This is called theranostic digital twin. In this, during radiopharmaceutical trials, when you take the data from the patient individually, you also take different characteristics of the radiopharmaceuticals, like the pharmacokinetics, the radiosensitivity of each and every patient, the various functioning levels of organs, and their individual immunological reactions. And all these will be combined during the clinical trials, and it acts, and the AI tries to integrate all these findings for each and every patient, and that will be used as a new standard for designing and also implementing clinical trials from now on. Just in conclusion, as you may have seen, that most of the references that I've put has come out in the last 5 years. So the field is pretty new, and it's sexy, it's exciting. And so many multiple agents are coming out. There are beta emitters, alpha emitters. They can be used as a solo treatment option or combination with external beam radiation or combination with chemotherapy. And when you compare it with other chemotherapy drugs, most of the times the radiopharmaceutical drugs are more, or have a better tolerability, have a less side effect profile. And the advancements in technology and computational levels towards quantitative dosimetry and personalization is much more exciting here. Thank you so much.
Thank you, Dr. Hari. We'll save questions at the end after Dr. Alexandrian's talk. So just to save some time for now, I would like to get Dr. Alexandria here for his talk on the medical physics latest advances in radiation therapy. Dr. Alexandria is a radiation physicist at Mary Bird Perkins. He's faculty with LSU, Graduate Program of Medical Physics. And I'm pretty sure it's going to be an exciting slide deck.
All right, thank you so much for introducing me, and thanks to the CAGLA for inviting me for this talk. Let's see if I can. Pull this up. So, as Dr. Stathakis said, I'm a medical physicist, so I'm primarily going to come from the angle of physics. And the deck that I've put together is kind of a survey of the last decade or so of innovations and advancements that have come in radiation oncology. No disclosures, so no one's paying me to say any of this. There's going to be a lot of different commercial products that I'm going to survey here, and there's many alternatives to each of the ones that I present. I have one slide that's out of order around slide 10, so I'm going to zigzag, so I'm going to apologize ahead of time, so just bear with me while I zigzag. So, there are 7 areas that I want to cover in this talk. That doesn't mean that there's only 7 areas of innovation, but these are the 7 that I felt I could wrap together in a continuous format that would be palatable. So, starting from image guidance, which is not like setting up the patient or diagnosing them, it's more so the imaging that goes into treatment time. So we want to localize and verify that they're in the right position while we're treating. And then we'll move into surface guidance and how that couples with image guidance and the innovations there. And then this concept of MRI as a modality for simulation images in radiotherapy as opposed to just diagnostic images that was previously the paradigm. Then, this wouldn't be a talk in 2026 if I didn't sprinkle some AI in there. My colleagues are probably surprised that I'm not going to have a lot of AI in there because I'm currently hijacked into Claude Code as we speak. And I do a lot of AI stuff on my spare time, but I didn't think it was going to be relevant for the survey talk that I'm talking about, so sorry to let you down. Then we'll talk a bit about radiosurgery advancements and some hypofrac palliative advancements and then some emerging tech. So, grand scheme of things, back then, which is before I started practicing, which isn't the origination of radiotherapy, but like say the 2000s, we had pretty much MV or high energy electron MV port films, which were 2D grainy images, but this would provide us with certainty up to half a centimeter to 1 centimeter when setting up patients. So our treatment planning and treatment was already kind of off on that scope. Then we're talking about lots of manual contouring that was going on in radiotherapy, which is a cumbersome task that Dr. Elson had talked about a little in his presentation. Just immobilization and markers that were necessary to get patients in the right spot. And the treatment paradigm was static. So what you planned was what you delivered to the patient for the most part. There wasn't any flex or give and take day to day to change the dose that was delivered to the patients. And now we're talking about sub-millimeter 3D volumetric images that are taken on treatment day to make sure that we're in the right spot. We have 1 to 2 millimeter precision when tracking. There's some AI integrated with the contouring it says seconds on my slide, but it's really on the order of minutes, but it's getting faster each day. And we can do single fraction SRS that can treat up to 50 mets simultaneously. We've got some surface guided advancements that can track patients in real time. And then, of course, we've got MR guided adaptive radio replanning available. So here, in terms of the image guidance, is kind of the flow of things of the major milestones in the last 2 decades, starting with the EPID image, which was kind of a replacement for port films. It digitized it, but it was very crude. and then moving into the cone beams, which gave us the 3D volumetric image, which gave us some more soft tissue contrast. Then 4D CTs is the combination of CT imaging with real time and taking multiple images so that we can track, for instance, the internal anatomy of a patient as they breathe to make sure that we can track as things are moving, we're treating correctly. Then comes the advent of surface guidance, which kind of couples with the existing technologies in order to give real-time monitoring. And then as we go forward, we're seeing more and more AI enhancements that tap into IGRT. But now let's talk about that first part, which was the portal image. So here on the left, you see a digital reconstructed radiograph, which is a ray-traced representation from the CT sim of what you're expecting to see when you treat the patient from the treatment machine's beam's eye view. There's a lot of words, but essentially when they're treating the patient, they're trying to line up the patient to that location so that they know that they're treating. And on the right is one of the earliest EPID images that was taken for a PEDS patient. And as you can see, the area that's dark in the middle is the exposed area that's overlaid with the DRR on the left. And you can kind of tell that there's some bony anatomy there and there's some ability to line up, but it's very crude. And definitely, in terms of soft tissue contrast, you're not really getting much of the story there. So as things progressed, some physicists decided, why don't we throw a cone beam machine and take a volumetric image on the patient before we treat them so that we can get way more detail and information. And so a group, Jaffray et al. In 2003, I believe, they were the first to do it, but they basically started taking cone beams while patients were being treated in real time. Now compare that to the fuzzy image of the MV image. You can tell there's a lot more contrast, especially where soft tissue exists. It's not as good as a diagnostic image or a planning image, but it's certainly much better than what the MV image provided, and especially where bone and soft tissues that are heterogeneous, where the interfaces exist, it's a lot more reliable in terms of making clinical judgment. So now physicians can show up to the patient, see the alignment, and say, yes, this is in the right spot, and I'm confident that we're going to treat within 1 to 2 millimeters. Now, the inherent downfall of these two imaging modalities, the MV and the cone beam, is once you take the image, you're assuming that everything stays static at that point. But what happens when the patient coughs, or if they're in an uncomfortable position for 5 minutes or more, like myself, if I'm lying stiff for 5 minutes, then I start to wince and wiggle. And so all of your alignment has kind of been thrown off. And so now we're going to move into the topic of surface guidance, which kind of tackles that problem. And so what this does is it implements cameras that emit light that reflect off the surface of the patient. And it can track in 6 degrees of freedom, that's X, Y, Z, and rotation, and give you real-time feedback of where the patient is located. And the accuracy, it can be as good as sub-millimeter for cranial patients, and it can be as good as on the order of 1 to 2 millimeters for non-cranial patients. And there's a lot of applications to this, and I'll talk about some of them, but just to drive home what sub-millimeter really means. So if you take a standard dice, one side of a dice is 16 millimeters. So when I say we're tracking sub-millimeter precision, I'm really talking about between that orange line and that 1 millimeter mark. I know we all know what a ruler is, but it's kind of phenomenal how amazing it is that we can track sub-millimeter precision where the patient is lying. And so essentially, as I described, there's lights that emanate from these cameras, and then there are detectors on the lights. And then, so as you get the patient cone beamed and you align them in the right position, you will snapshot a reference image or a position of the patient in that configuration. And so right there, you lock in what the reference position is. So if the patient coughs, they're going to wiggle and come out of tolerance perhaps, and then you know that you would have been missing them before surface guidance was a thing. But thanks to surface guidance, you can correct, re-image, and treat correctly. So I gave a little heads up about a zigzag slide, so that we're going to ignore that one and go to this one. So here's an example of what it would look like. So if you took your patient that's being treated for breast, you could image a region of interest of the breast and track that. And so you can see in this case on the bottom right of the GUI, let's see if I can put the laser up. Nope, but on the bottom right, you can see there's a green area where it's highlighting the breast region, which is the area of interest when we're treating a breast patient, of course. And you can see that there are metrics being tracked there for X, Y, Z, and rotation. But the one in the middle, which is probably hard to read out, says 0.49 millimeters. So it's half a cm off, and that's the net displacement. So in this case, if we didn't have surface guidance and we just locked the patient in and said we're going to treat, essentially we would have been off the remainder of the treatment by that much. But with surface guidance, we can correct that. Okay, so there are many, many other applications of surface guidance beyond just localization. You can use it for maintaining accurate deliveries during breath hold treatments. For these breast patients, oftentimes we'll do a deep inspiration breath hold technique, which pushes the chest wall out, which creates more separation between the treatment field and the heart. And for each incidental gray of dose that the heart receives, it adds 7% increased risk of heart attack after 15 years. That's what the data shows. So we really want to minimize as much incidental dose that the heart can get. And so by using surface imaging, not only are we telling the patient to hold their breath, but we can also make sure that they're exactly where they need to be for the treatment. And then I have highlighted there frameless SRS and SBRT, that's stereotactic radiosurgery and stereotactic body radiotherapy. These are typically high-dose treatments that are given in 1 session or 1 to 5 sessions for SBRT. So the stakes are high and you really don't want to miss. And on the bottom right, there's a patient there that's set up for a cranial case. And you can see that he has a mask that's locking him into the table. And by using surface image, we can track that there isn't significant motion during treatment. And like I said, for the cranial cases, they can be sub-millimeter there. So there on the magnitude of the XYZ coordinate, the 3D shift is 0.08, that's 0.08 centimeters. So that's 0.8 millimeters, which is very tiny. Okay, so then I'll zigzag back now to this slide, which is transitioning into brain meds. So there's kind of been a paradigm shift in brain meds in the last decade or so. Conventionally or traditionally in the past, not traditionally, but historically, if a patient had 1 to 3 meds, due to throughput issues and just the technicalities of treating a radiosurgery and all of the tightness that's required to make a smooth and safe treatment, if they had more than 3 meds, you essentially were going to give this patient whole brain radiotherapy. And whole brain radiotherapy comes with significant neurocognitive decline, like it's essentially going to happen. And in this case, the patient would be coded palliative, and all the things that come with that. But with the new paradigm, we're able to treat multiple mets with stereotactic radiosurgery. So there's going to be a palliative patient, but by using the SRS technique, which really dials in and pinpoint targets each of the mets, you're avoiding you're preserving neurocognitive function during those treatments. And then, let's see, so now I'll transition back. We're done with the awkward slides. I'm going to talk about the historical gold standard known as the Gamma Knife. Now, Dr. Elson showed some isodose lines from a Gamma Knife patient that he had treated previously, but this machine essentially was the gold standard for 5 decades. And today's implementation has 192 cobalt sources that's positioned in a helmet-like configuration. And each of those sources is pointing to one singular spot. And you can modulate the aperture and kind of change the size of each individual shot's hole or aperture. But essentially, you're doing sphere packing at an isocenter, and then you're shifting the couch around to get that to different mets. And I said we were talking about the cone beam, and that was online in 2005, so that's not really relevant to this decade. But in the context of Gamma Knife, it's actually very relevant because they only brought that into the Gamma Knife workflow about 10 years ago. So before that, patients had to get frames bolted onto their skulls. Then they were rigidly placed into an adapter that bolted them and basically locked them in place. And that was the standard for Gamma Knife. But now using the cone beam and some surface or surrogate surface imaging techniques, we can track patients with masks and not even have to use the bolt. And we use the cone beam CT to generate the skull as a reference image. Now, the downfall of the Gamma Knife, though, it has many pros, but one of the biggest downfalls is that it is cobalt-60 sources, the activity of which is not so high. And when you first install the cobalt-60, the activity is at its peak. But the half-life is 5.25 years. So that means after 5 years of treating, essentially the activity is at 50%. And what that translates to is double the treatment time. So what used to take 10 minutes would be 20, and if something took 90 minutes, it takes 180 minutes, which is a long time to be in a treatment position. So now, the new paradigm, or the new movement for linear accelerator-based SRS is using single isocenter multi-target SRS. So these linear accelerators have a lot more dose rate, or higher dose rate, and they can treat significantly faster than the Gamma Knife. And historically, linear accelerators, you had to put cones on them to make really small apertures to get them dialed down to accurately treat lesions, which meant you had to shift the patient into multiple spots. But now with the advent of really fine MLCs and better technology with HyperArc, you're able to use a single isocenter and treat all of those mets simultaneously by going through 1 through 4 arcs. So there was a graph on the bottom, but I'm going to zoom in on it. So this is a study by Thomas et al. In 2014, where they retrospectively took 28 Gamma Knife plans, and they replanned them using the HyperArc, and they computed the differences in beam time between Gamma Knife and the HyperArc on a linear accelerator. And these aren't box plots, these are bar charts. So what you're seeing is the average. So on the left, you can see the beam time for the Gamma Knife was past 50 minutes on average. And on the right, you can barely even see the bar for the linear accelerator because it's on the order of minutes when it comes to beam time. That's just the time that's when you're beaming on. For total treatment time, of course, there's getting the patient, verifying them, putting them on the table, taking images. Maybe they coughed, you have to re-image them. So if you incorporate all of the fuzziness that goes into treatment, the times get a little bit longer, but you can see the Gamma Knife is on the order of 150 minutes versus something that's 10 to 20 minutes for the linear accelerator. So that sounds amazing, but if you're a rational mind, you're thinking there has to be a trade-off, right? So in that same study, they computed lots of the metrics. I apologize, it's kind of small, but the 4 on the left are basically low dose to high dose isodose line metrics that are commonly tracked in Gamma Knife or stereotactic radiosurgery plans. And on the left and the right, you see the scatter of individual plans versus the box and plot or the quartile range of the plans for Gamma Knife and then HyperArc for each one of those plots. The takeaway here, you don't really need to zone in on any of the values, is that overall, they're pretty indistinguishable, especially as you go to higher doses. And on the right side, you have planning metrics such as the conformality index and gradient index. And again, the same thing you see there. Now, there, of course, they trade blows if you look at different settings. Like if you have a very, very, very small target, the Gamma Knife is going to edge out the linear accelerator. But we're talking about patients that were getting whole brain before, right? So this is a big win because we're able to give treatment to patients that were just going to get a whole brain with neurocognitive decline. And it only takes 20 minutes, so it's quite an achievement. And then on the bottom, there was a case study in 2022 where they took a patient that had 53 METs, treated them with HyperArc, and essentially achieved all the planned quality metrics that they would have on their Gamma Knife. And it's quite a change from what it is in the last 10 years. So then that was the brain, but how about the rest of the body? You've got to show that some love too, right? So SBRT has been around for about 15 to 20 years in our field, but when it was first introduced, of course, we're very conservative and scared about introducing toxicities and treading in the unknown. So it was we were kind of in the fog of war in the early SBRT days. But as data has been collected and outcome studies were taken, we got more and more courageous. And of course, I discussed some of the advantages of the IGRT and the implementations of surface guidance. So when you combine those technologies and the advancements that they've made in our ability to confidently treat, people are getting a little bit more comfortable with the idea of increasing dose per fraction and going into the SBRT paradigm. And so the SABRE COMET trial in 2023 is an interesting one because it took patients that would have ordinarily been coded as palliative patients and would not have been treated with SBRT. And so in the control, they had the palliative patients, and in the non-control, or in the study, they had the patients that were receiving SBRT. And they found pretty phenomenal results that with the 5-year, in the 5-year rates, they got 42.3% versus 17.7% versus the standard of care. And you got double the survival, and your progression-free survival was also double. So pretty significant improvements made with SABRE COMET trial. Now, it's not all rainbow and sunshine. I didn't put in there that there was actually increased grade 2 toxicities, but those were primarily on the order of 10% for pain and fatigue, and these aren't debilitating endpoints. These are manageable, and anything that was grade 3 or higher in the realm of pneumonitis or fracturing, these kinds of things were insignificant. So it's a pretty remarkable trial. Here's my sprinkling of AI for this talk. Auto-contouring, as Dr. Elson has said, it used to be a research topic in our field, but it's definitely standard practice now. It's not to say that the AI models don't ever mess up, but it's nice to have 20 to 30 contours ready for you that you can go and then spot fix and just kind of pad it in and boom, you're good to go. So it's really increased throughput and efficiency for the clinic. Then treatment planning, we're not really at fully autonomous treatment planning, but we have made significant advancements by utilizing knowledge bases. So there's a technique or a product called Rapid Plan, which can build knowledge base based off of your patient cohorts, and you take DVH-based metrics, and it can create a knowledge base to help you instantly launch into a plan that's almost ready to treat. It's gonna need some tweaks, but it's not fully there. And then quality assurance is probably the most boring thing, but it's unfortunately one of the most important things as a medical physicist. I have to make sure these machines are dialed in. But it's really boring because it's really cumbersome and just very granular data metric keeping. But AI is definitely useful there because we have decades of these cumbersome data points that we've taken, and we're building models, and it helps accelerate the trend lines and the kind of forecast models that we use for QA to prevent any kind of drifts on our machines and treatment types. All right, so then MR-Linac, the one on the left, the image on the left is a Elekta Unity, and this combines a linear accelerator and MRI imaging together. So it's a package that gives you the ability to use MR images in real time while treating on a linear accelerator. And the one on the right, the Varian Ethos, this is, it's a linear accelerator modified in a really compact form, but it doesn't have an MRI, it has a very high spec CBCT or cone beam CT. And so because the Unity has the MRI, it's able to get a little bit better images, and also it can leave it on real time, so you can monitor patients while you're treating them. So you can actually see what's going on in the patient while the beam is on. The Ethos, unfortunately, cannot do such a thing. It takes a cone beam CT, it snapshots it, but it couples surface guidance with it. So as long as you're in the realm of where your reference image was taken for the surface guidance image, you still feel confident that you're treating where you were simmed, or sorry, where you were positioned. And so generally the workflow is you'll get some sort of an image on the day of treatment. You're gonna implement some auto-contouring technique. When adaptive systems first came online, they weren't using AI, they were doing manual, so it slowed things down. Now that AI is introduced, you're rapidly getting some sort of contouring that's getting you right into the picture. You might re-optimize the plan if a significant shift has happened from day to day, or if the anatomy has changed. You're gonna do a real quick in-house QA or some sort of a dose calculation QA, and then boom, you're going to treatment and you're monitoring to make sure that they're in the position that you're treating. And then I put a link on the bottom for a pancreatic cancer study in 2019, which showed that the 2-year survival rates for non-operable pancreatic cancers, they jumped up from 30% to 49%. So that was one of the earliest evidence-based studies that showed the benefits of adaptive radiotherapy. And I don't know, I think it'll be interesting to see what comes out around the corner. So I think more and more is gonna come. And on that topic for MR-based treatment planning and, well, with the Unity, you're using MR images and you're using an MR sim. So this is kind of a different paradigm from radiotherapy because typically we're always using CT images, which don't have great soft tissue information the same way that MR can provide. But the problem is in 90% or more of our dose calculation engines, they rely on information that comes from the CT, which is the electron density, which is converted to a Hounsfield unit, and then this information is used for the algorithm. But now, with the advent of synthetic CT, you can take an MR sim, convert that to a CT. It's in the exact same configuration that the MR was taken, so you don't have to introduce any fusion or registration algorithm errors. And you can use the CT that was synthetically made in that same position to do your calculation with your conventional dose calculation algorithm. So this is a game changer in terms of workflow. It really speeds things up for us, but it's also great for the patient because they don't have to also do an MR on top of a CT. We can just have that information and save them one part of the procedure. Okay, so proton therapy. Proton therapy has been a buzzword for probably 15 to 20 years in this field. But in the last 10 years, it's probably proved that it's not going anywhere. So the number of clinics or proton centers has jumped up from 15 to 45 in the last 10 years. There are significant dosimetric advantages for certain disease types and demographics, such as pediatrics when treating protons. For instance, their entrance and exit dose on photons is kind of a problem when you want to limit toxicity for certain sites, but when treating with protons, they don't exhibit the same exit dose characteristics that photons do, so you can really have a sharp edge. So for nasopharynx, or in the case of peds, anything, you're just kind of minimizing that spillage on the other end. Now, what's different technologically in terms of proton therapy? In the beginning, they didn't have really good IGRT at all, but all of the techniques that I discussed in the beginning of this talk have kind of been layered into proton therapy. So they're starting to use cone beam CTs in the room with a C-arm. They're implementing surface guidance, and you know, it's come a long way. So flash radiotherapy is kind of a major buzzword, especially in 2021, 2022, big buzzword, because in conventional linear accelerator treatments, like on the paradigm of 25 to 35 fractions or treatment sessions, your dose rates are on the order of 0.01 to 0.4 grays per second. But when you're talking about the flash paradigm, you're delivering 40 grays per second. It's delivered all under 1 second in one session. And the claim is that this is giving you tumoricidal effect, so killing the tumor while sparing normal tissues. And the biology is not really well understood right now. There's a lot of studies trying to uncover why this is working. It's a lot of interesting studies coming out of animals. But the first human patient treated with flash was in Cincinnati Children's 2023. They were a bone mets patient. So clinical trials are starting to enroll for flash, and there's a flash consortium where more and more centers are starting to try to understand what the biological effects are. And then I'll end it here on next generation treatment machines. So on the top is a really cool looking machine, it's a ZapX. It's a radiosurgery machine like the Gamma Knife, but it incorporates technologies and methods of the linear accelerator with a single isocenter multi-met and the shape and delivery of the Gamma Knife. But the really cool thing about it, other than how futuristic it looks, is it's self-shielded. So you can actually throw it into a room with windows, with panoramic views of the ocean or something. So it doesn't have to be in a radiation bunker with concrete walls. And that's kind of a really cool thing. And you know, that kind of stuff can matter for patients' quality while they're being treated. If they're in a bunker-style treatment versus a floor-to-ceiling panoramic view of the ocean, I think that can help with their stress levels and things like that. So that's really cool. I don't have a picture of it, but the Elekta Evo platform, it's not a new machine, but it's a new platform that's coming to existing machines all over. So there's a large volume of these Elekta machines. At Mary Bird Perkins, we have about a dozen or so. And they don't have any kind of means to adapt, but what they're incorporating is some AI technologies in this platform that will let you leverage adaptive techniques. Not as good as an MR-Linac, but it's something, right? And some patients don't need a lot of adaptive. They just need a little bit of adaptive, and it can have a significant impact. So they're rolling that out to kind of bring the rest of their fleet up to speed. And then the wildest one, I think, that I'm going to talk about is the reflection. So this system is a PET, or a biology-guided radiotherapy system. So what you do is you administer PET FDG into a patient, and the device actually has PET detectors situated all around it, and as it detects activity from a certain location, it will immediately put the linear accelerator there and zap the tumor at that location. So this eliminates contouring, SIM images, and all this kind of stuff. You just give the patient some FDG, you put them on the treatment plan, on the table, and then it just kind of goes. Now it sounds like sci-fi, but they actually got FDA cleared for lung and bone mets in January 2026, so it's coming. So my key takeaway for the survey is, like, lots of the stuff has been around, but the way the marriage of the different technologies is coming together is quite enabling, and it's ramping up. For instance, with the Comet Sabre trial that I described, like, it's not that we weren't able to give the doses that they did in those trials, but it's that we have the confidence to go where we didn't have the confidence before because of all these enabling technologies. And you know, it's a really exciting time in our field, especially with the marriage of AI on top of all that. So here are some references that I put together so you don't think I'm blowing smoke, and take any questions.
I think we did pretty good in confusing you all and throwing all these buzzwords and difficult ones, from theranostics to reflection, image fusions and registrations. We do have time for questions, for at least for Dr. Alexander and Dr. Hari, if you have any. I would also like to say that I hope you can appreciate how the three can coordinate and work together. Whatever theranostics cannot treat, maybe with the help of AI and next generation machines, Dr. Elson can target it. Am I right? And with the help of physics, we can bring them all together and do the best for our patients. Any questions? If you don't have any questions, you can have more coffee outside. I hope they still have cookies too. Well, thank you so much, Dr. Hari. Thank you so much, Dr. Alexandria, and thanks everybody for attending this session. I think it was really exciting.
Okay, okay. I'm standing by. Hey. How are you? I'm doing just fine. He's sending me some updated slides and everything else ready to go. You're welcome. I'm refreshing. Wait. Oh, perfect. Okay. Download. Absolutely, absolutely. So usually we tell people it just depends on how busy we are, but yeah, we got some free hands, so we're good. You caught me in the right time. So this is the previous one, so I erased that. So all you have is your this one. Okay.
Thanks. Cool.
Very well. Just going right back to 2.
I guess we can get started. Thank you all for coming. We're going to have a great session today about topics dealing with pediatric and young adult oncology with some really great speakers today. The first, who I'm meeting for the first time, even though he's just across town, Dr. Benjamin Watkins. He's at Manning Family Children's, which I always call Children's of New Orleans, is going to be giving a talk today on new therapies for managing a really difficult problem that we have when we do stem cell transplant, which is graft versus host disease. And if I went out on a limb, I'd say abatacept is going to be mentioned here because Dr. Watkins actually was a lead author on some of the initial papers for abatacept when he was at Emory. Welcome.
All right, thank you all for having me. So yeah, we're going to be talking about graft versus host disease prevention and some of the new novel approaches that are out there. I've seen a lot of changes. I've been doing this for maybe 15 years or so, and when I started this, there was like only a couple of options for the prevention of graft versus host disease. So in the past 10 years or so, we've just seen a real explosion in what we can now offer, which is really exciting. And so we'll go through some of those, some disclosures. I also wanted to start with some disclaimers. One, obviously there isn't enough time to discuss all the approaches to graft versus host disease prevention. There's a ton that are out there. And so we'll hit the high points, kind of do the 30,000-foot view. Also, I want you to take caution when I talk about some of the numbers that we're seeing when it relates to rates of graft versus host disease, because it's really difficult to compare these studies without a randomized control trial. There's so much heterogeneity in these trials. There are peds and adults, there are different donors, there are peripheral blood stem cells, there are marrow stem cells. So it's really hard to compare these without a randomized control trial. And then one of the other things that I find really challenging in the field is that there's no consensus on what outcome to measure. So when you talk about a graft versus host disease trial, we used to really focus on rates of acute and chronic GVHD because that's what the trial is for. And that's really important, but what it doesn't take into account is you can eliminate graft versus host disease, but then you may die from infection or relapse or something else. So it's really important that you actually capture both of those, because it's not just about reducing graft versus host disease, it's more complex. But then the new challenge that's now arisen is as composite endpoints has become more popular, things like graft versus host disease relapse-free survival, which tries to capture those, is that one, every study seems to define it differently, but also it equally weights graft versus host disease and death, so that you get counted as an event if you have, grade 2 or grade 3 or 4 acute GVHD that may be responsive to steroids, the same as if you died, which I don't think personally, I'd rather have GVHD than die. So I think it's really hard when looking at these studies because of this lack of consensus. So I figured I'd start by talking about some of the mechanisms of acute graft versus host disease. So the cascade of events that leads to graft versus host disease begins well before the actual transplant's given. So it may be the underlying disease or conditioning regimens, but it causes a lot of tissue damage. And so I don't know if you've ever seen anybody going through transplant. It's a really difficult process. The patients are very inflamed. That tissue damage leads to the release of chemokines, pathogen-associated molecular patterns, gut commensals, et cetera, that activate host antigen-presenting cells. So these host antigen-presenting cells go around and collect the self-antigen, express it on their surface. And in people that aren't going under a transplant, our T cells would see that self-antigen and say, that's you, ignore it, you don't need to react to it. But in the setting of an incoming graft that's filled with T cells, they'll interact with those host antigen-presenting cells and see that self-antigen and not recognize it because they recognize the donor who they're no longer in. So that interaction of those T cells and those antigen-presenting cells causes massive activation and proliferation, which leads to the symptoms of graft versus host disease, which causes more tissue damage, cytokine release, kind of feedback into it. So what I circled there in red, that's where most of GVHD prevention and acute GVHD takes place, is that interaction between antigen-presenting cells and T cells and that T cell activation. Chronic GVHD is much more complex. Acute GVHD, by comparison, is pretty simple. It's mostly driven by that T cell activation. But in chronic GVHD, you again have T cell activation, but you also have macrophage activation that leads to tissue fibroblast proliferation and scarring. You have antibodies that are being formed by your B cells. You also have decreased T regulatory cells, which shut off the massive immune response that happens with acute GVHD. So you don't have the brakes on the system. So chronic GVHD is much more complex. That's why our treatment for it is more varied, and there's a lot of different medications that are there. So I wanted to start by talking about what are the standard approaches to GVHD prophylaxis. So TAC methotrexate has been the standard, or calcineurin inhibitor, cyclosporin before TAC, really since the 1970s, early 80s. But subsequent to that, there has been a couple of new additions that have become standard of care. First one is probably the most commonly used, which is post-transplant cyclophosphamide. And its mechanism of action is really fascinating. And what you do with post-transplant cyclophosphamide is typically with the transplant, you start your immunosuppression before the graft is given so that you prevent T cell activation. But here you actually want T cell activation. So you don't immunosuppress them, you allow those T cells to become activated, you see massive expansion, and then you come in 3 days later and 4 days later and hit them with cyclophosphamide, which kills the proliferating T cells. So you're hopefully selecting the non-reactive T cells. And those non-reactive T cells tend to be those that are adding to our protective immunity. They're CMV specific, they're EBV specific. They're actually helping you prevent infections as you go on. So there's been lots of studies. Post-transplant cyclophosphamide has been used for decades. This is one of the recent studies. It typically had been used in the haploidentical setting primarily, but it's since come into other donor settings. So BMT-CTN 1703 was a study that compared post-transplant cyclophosphamide combined with TAC and mycophenolate mofetil to TAC methotrexate. And so the patients were randomized. This was mostly adults, and that received match-related and match-unrelated donors. They included mismatches, but that was only 3% of the total, and this was peripheral blood. And so what was found here was that the addition of post-transplant cyclophosphamide was able to significantly reduce the rates of acute graft-versus-host disease as well as chronic GVHD. It also led to an improvement in the chronic graft-versus-host disease relapse-free survival. But interestingly, it didn't necessarily lead to a statistically significant improvement in overall survival or disease-free survival. ATG is anti-thymocyte globulin, so many of the room, I'm sure, know this drug well. This is used for a variety of different things. So this is an antibody-mediated clearance of T cells. There's multiple different antigen targets, as shown there on the bottom. And so the ATG will bind to the T cell and result in depletion of those T cells and clear them. There are a lot of different ATG formulations, though. So they don't just differ in their doses or half-lives, but also the degree of lymphopenia, their antigen targets, and their impact of graft-versus-host disease. The Europeans have gotten really good at using ATG. There's an art to it. Some places are using PK. They're changing the dose based on how many lymphocytes you actually have. And so we haven't really caught on as well here in the US. There's some places that are doing it, but a lot of the ATG data is not quite as good, and I think it's because they just have a better approach in how they use ATG. So the New England Journal study that came out now a few years ago, also similar to the PT-Sci study, combined it with a calcineurin inhibitor methotrexate, and it was randomized to patients that just got the calcineurin inhibitor methotrexate. This was in the match-related and match-unrelated donor setting, and so this was very similar to what we saw in the PT-Sci group. And so in this group, what we saw is that there's no significant difference in the acute graft-versus-host disease, but there was in chronic GVHD, really a striking reduction from 47% for moderate to severe chronic GVHD down to 11%. So ATG seems to be really effective at preventing the chronic GVHD, but maybe not as well at the acute GVHD. But again, importantly, when you look at the overall survival and disease-free survival, there was no significant difference, and at least numerically, survival was actually lower in the ATG group compared to the calcineurin inhibitor methotrexate, but didn't reach statistical significance. The other drug that's probably the most recent on this list is abatacept. So abatacept was FDA approved for the treatment of rheumatoid arthritis in the late 90s. It is a fusion protein of CTLA-4 and the Fc portion of IgG1. So what it does is as ATG binds to T cells and results in clearance, this actually binds to the antigen-presenting cell. And so it binds to the co-stimulatory molecule present on the surface of the antigen-presenting cell and prevents T cells from interacting with it. And so this prevents T cell activation, obviously, but also importantly, compared to ATG, it doesn't deplete T cells. And that's important because later on, when it comes to protective immunity, we think that ATG may have a little bit better effect because it's not depleting the T cells. So abatacept is a drug that I started working on in the lab in 2011, and has subsequently moved from small animal models into the adult setting. And so our large trial was the AB2 trial, which again, similar to the other two, had a control arm that was calcineurin inhibitor methotrexate, and abatacept was combined with CNI methotrexate. We did two different arms, a matched unrelated donor and a mismatched unrelated donor. Importantly, this study included a large number of pediatrics. This was about 30 to 40% pediatrics. And what we found was really a pretty striking reduction in acute graft-versus-host disease. So our grade 2 to 4 acute GVHD was decreased in both the matched and mismatched setting. In the grade 3 to 4 was really striking in the mismatch setting. So in the mismatch setting, the control group had a GVHD rate of 32%. That was 0% with the AB arm, so none of our patients had grade 3 to 4. And historically, this may have been before Jakafi and a lot of the other meds, when you develop grade 3 to 4 acute GVHD, historically it carried about a 50% mortality rate, especially in the adult setting. So this was very promising. But importantly, it didn't seem to reduce chronic GVHD. Chronic GVHD was nearly identical between the two groups. There was no difference. However, survival was significantly improved, especially in the mismatched unrelated donor arm, with a 2-year overall survival of 77% compared to just 45% with calcineurin inhibitor methotrexate. So we haven't really come up with a consensus here in the US, but the Europeans have. Abatacept has not caught on in Europe as it has in the US. It's only approved, I think, in Germany and Israel and maybe one other country. And so they use a lot of ATG. And so this came out last year and a half ago now, that now for every type of donor that you use, they recommend either adding ATG or PTCy. And they really strongly recommend ATG. So the standard calcineurin inhibitor methotrexate, I would say, is no longer standard for the vast majority of transplants. There's a handful I would still use standard, but that's few and far between. So what is the current standard? For haploidentical setting, right now it's still post-transplant cyclophosphamide, but in the matched unrelated, mismatched, and the matched sibling, there's no clear superior agent. And so I think the approach that a lot of people use is more a personalized approach where you take into account the factors of the patient, the risk for infections, the risk of relapse, because you may choose something more immunosuppressive or less immunosuppressive based on those risks. Next, we want to talk about kind of the newer approaches and why do we need these new approaches. It's partly because despite these advancements, graft-versus-host disease still remains one of the leading causes of morbidity and mortality after transplant. So we really haven't solved it with agents that we have now. And all this additional immunosuppression, whether it be ABA, ATG, or post-transplant cyclophosphamide, comes at a cost. You get delayed immune reconstitution, increased infections. Sometimes, especially in the PTCy setting in pediatrics, the graft failure rate was quite high. It was 16% in the most recent one, so that's definitely a concern in certain settings. And then its impact on graft versus leukemia. And so there's really a need to try to thread that needle between GVHD risk and the toxicity. And so we'll go through several different categories of these new approaches, starting with the new approaches using these proven agents that I just talked about. So one of the upcoming studies that's ongoing now is OPTIMIZE. So the OPTIMIZE study is actually looking at reducing the dose of cyclophosphamide post-transplant. So the dose of 50 mg per kg at day 3 and 4 is something we've used for decades. That was largely based on some animal model. No one's ever deviated from it. I think a lot of us think that maybe we don't need that much cyclophosphamide, but are too afraid to lower the dose. And so that's what this study is doing, is looking at dropping it from that 50 down to 37.5, and then if that's successful, to drop it to 25. And this is highly mismatched donors, 4 to 7 out of 8 unrelated donors. So that study, we don't have data on that yet, so that study's ongoing. Abatacept has also got several ongoing trials. And so there's several different groups that are looking at, can we extend the dose? So the standard approach with abatacept is giving doses on day -1, 5, 14, and 28. And so the thought is that may be too short to really affect chronic GVHD, because by day 60 or 70, all the abatacept is gone. Those T cells are now able to become activated, and so the onset of chronic GVHD is after that period. So can we extend it out to either day 150 or even to 1 year, especially in the setting of a non-malignant transplant? And there's been some mixed results on that. So there's really positive results in some of the sickle cell data that's shown a really impressive reduction in chronic GVHD with that extended dosing. And so our follow-up to the ABBA-2 study is the ABBA-3 study, which is we've closed to accrual other than our very young patients, but this is looking at randomizing between that standard 4 doses or extending it out to day 150, and this is pediatrics and adults. And so more data to come with that. I don't know if that's going to be the answer for chronic GVHD. I think we'll probably still see it. We may just be kicking the can down the road with abatacept. I think maybe the real answer is actually combining it with other agents, which we'll talk about subsequently. And then there has been a study looking at a calcineurin inhibitor-free transplant. Those who are familiar with transplant know a lot of our complications are coming from our calcineurin inhibitors, and it's really challenging. And so this, we'd love to find a way that we can get away without tacrolimus or cyclosporin. And so the CTN 1301 was a study that was published a few years ago. That was a phase 3 study that was randomized to just CD34 selected, so just collecting your stem cells, eliminating all of your T cells, since those are the ones that cause the problem. Then comparing that to just standard post-transplant cyclophosphamide, and then comparing that to TAC and methotrexate. And so interesting what they found is CD34 selection is excellent at getting rid of graft versus host disease. So it had the lowest rates of acute GVHD and chronic GVHD, but it also had the highest rates of relapse and infections. So the overall survival was actually significantly lower despite the acute and chronic GVHD rates being so low. And so CD34 selection, that standard approach, doesn't seem to be the answer. And then when they compared post-transplant cyclophosphamide and TAC methotrexate, they saw no significant difference between those. And so that, with just post-transplant cyclophosphamide, it doesn't seem to be enough to do a calcineurin inhibitor-free transplant. And so, again, I think one of the best approaches moving forward, in my opinion, is actually a combination of agents. And so one of the ones that there's several different trials looking at this, but they call it CAST, which is a combination of post-transplant cyclophosphamide plus abatacept, and in this case, plus tacrolimus. So this is a phase 1b/2 trial. There's several other trials that are, again, out there, but looking at this in the haploidentical setting. And so what they found with this regimen is that really low rates of acute and chronic GVHD and encouraging survival. And so they didn't have a control arm, but the rates of grade 3 to 4, the most severe acute GVHD, was very low, as was the chronic GVHD, and the 1-year overall survival was 86%, which is quite reassuring with this patient population. There's still more approaches trying to get towards calcineurin inhibitor and free transplant. Again, the PTCy alone doesn't seem to be the answer, so this is one that's actually trying to combine PTCy plus ABA, so it's using ABA extended dosing as kind of your maintenance to prevent GVHD, and combining that with post-transplant cyclophosphamide. So this was presented at ASH. I think this is due to be published within the next month or two. So this was a phase 2 randomized trial, and it showed, again, low rates of acute graft versus host disease, but importantly, 0 patients developed moderate to severe chronic GVHD, and the 1-year overall survival was 92%. So this seemed really encouraging. So there's several other centers that are out there looking at this ABA-PTCy combination. And then also wanted to share a little bit about some of the newer agents being evaluated. One of these is vedolizumab. Vedolizumab is a drug that's FDA approved for the treatment of Crohn's disease. It's a humanized monoclonal antibody that binds to the alpha-4 beta-7 integrin leukocyte receptor. It blocks the interaction between the MAdCAM-1 on endothelial cells and the GI lymphoid tissue, and it prevents the alpha-4 beta-7 expressing T cells from actually entering the gut tissue. And so this study was really focused on gut GVHD because this is really only active in the GI tract. It is not going to do anything to prevent skin or liver graft versus host disease. And so in combination with the calcineurin inhibitor, they found that there was a significant reduction. That's kind of hard to see on this slide, but the gist of it is that it was really effective at reducing lower GI GVHD, but again, has no impact on skin or liver, and unknown impact on chronic graft versus host disease. JAK inhibitors are also drugs that we use on a very regular basis in the treatment of acute and chronic GVHD. So this is Jakafi as an example of it. There's several different JAK inhibitors that have been evaluated. JAK inhibition reduces differentiation, proliferation, and trafficking of T cells. So the three primary ones that have been evaluated are itacitinib, pacritinib, and ruxolitinib. Itacitinib is a JAK1 inhibitor. Pacritinib is a JAK2 inhibitor. I'm not going to show that study because it showed no improvement. And then ruxolitinib is a combined 1-2. And so the itacitinib trial was just a single-arm study, included 59 patients. It was a phase 2 study. There are limited data that's out of this. This is from an ASH meeting a couple of years ago. Median follow-up was only 6 months, so can't really comment on chronic GVHD, but the rates of acute GVHD overall seemed not that impressive, 8 to 10%. So we'll see when the long-term data comes out. Itacitinib's also been combined with post-transplant cyclophosphamide, and so that's been encouraging with low rates of acute and chronic GVHD. This was presented at the transplant meeting last year. It's only 30 patients, but it does seem to be promising. And then the one that I think probably has the most promise, the drug we're most familiar with, is the combination of ruxolitinib with TAC and methotrexate. And so this phase 2 single-arm trial, this was focused on older adults because they weren't able to tolerate some of the more intense GVHD preventions. Again, showed encouraging reduction in grade 3 to 4 in chronic GVHD. The ongoing study is called BMT-CTN 2203, which is going to randomize between ruxolitinib, TAC methotrexate, and post-transplant Cy, TAC, and MMF. And this is one of the few studies that is actually randomized between two approaches using something more than calcineurin inhibitor methotrexate. And then the last group I'm going to talk about is graft manipulation, which also shows a lot of promise, but is logistically more challenging. So the one that's shown the most promise and has the most pediatric data is alpha-beta T-cell depletion. So the limitation, as I mentioned before, of the CD34 selection is patients die of infection, they relapse. If you eliminate all the T cells, you're going to have bad consequences of that. And so alpha-beta T cell depletion is really looking to thread the needle because alpha-beta T cells have been shown to be the ones that cause graft versus host disease, whereas gamma-delta T cells have no alloreactive activity but do play a role in graft versus leukemia and innate immunity. So how can we have both prevention of GVHD and still maintain our GVL? And so this study, which was a phase 1-2 trial, this was all in pediatrics that combined alpha-beta T-cell depletion with CD19 depletion in haploidentical settings. It showed really low rates of acute and chronic GVHD, 0% in the chronic GVHD moderate to severe. Importantly, these patients did not require a calcineurin inhibitor. What was also seen is it's not as perfect as we had hoped, that you still see delayed immune reconstitution, and they saw frequent viral infections. 62% of patients had viral infections at 1 year. And so it's not quite as perfect as we had hoped because you still definitely have some immune suppression. But they actually have 10-year data, which you never see in transplant, with still really promising results as far out as 10 years, with overall survival of 75%. Naive T-cell depletion is another approach, again, focusing on trying to maintain your innate immunity but eliminate your GVHD risk. So alpha-beta T cells include naive, effector, and the memory subsets. Your naive T cells seem to be the ones that cause most of the graft versus host disease. So this is looking at eliminating those naive T cells. And this is also a pediatric study by Marie Bleakley out of Seattle. And so what they do is actually collect the CD34 T cells, and then they deplete the CD45RA, which is a naive T cells, and then you infuse it back, combined with tacrolimus and methotrexate. And again, very low rates of grade 3 to 4 acute GVHD and moderate to severe, but they saw a lot of the more mild forms of GVHD for some reason. So the subsequent study is ongoing. So that's this phase 2 study, which we don't have results of yet, but will shortly. And then lastly is the ORCA-T. So ORCA-T is relatively new to the game. What this is CD34 selected Treg engineered graft. So what they do is they collect the stem cells and separate out stem cells, Tregs, and conventional T cells. And so they purify them separately. On day 0, they give the stem cells and they give the Tregs and allow the T regulatory cells to expand, because again, T regulatory cells are the ones that shut off your T cell activation. And so then 2 days later, they infuse the conventional T cells, but they do it at a ratio of 1:1 with your T regulatory cells. So trying to control how many of those T cells that you have there. And so this was presented at EBMT last year and also at the TCT last month. And so this phase 3 randomized study of 138 patients, this was randomized to ORCA-T and TAC versus TAC methotrexate. Really what showed an impressive reduction in graft versus host disease in both the chronic GVHD and a chronic GVHD-free survival. And so there's more to come with that study, but in conclusion, I think the standard of care for GVHD prophylaxis is still very much up for debate. That's the exception to that is PT-Cy for haploidentical transplants. I think that's still very much the standard. We've shown that PT-Cy, ATG, ABBA, all of these have shown superiority to standard calcineurin inhibitor methotrexate in multiple randomized control trials across many different donor types, and that calcineurin inhibitor methotrexate should no longer be considered the standard of care when choosing a control group too, because I think clinically that's not what we're doing. But there's obviously need for more head-to-head comparisons to find out really which one of these agents may be superior. And there's multiple novel approaches to GVHD prevention that have shown promise. There's none of these that seem to be superior. There's several out there that seem to have hope. And I think it's important to remember that every agent that we use comes with its own risks and benefits, and we have to keep in mind that we should be basing our approaches off of the patient that's in front of us and their individual risk factors. So with that, I'm happy to take any questions. Yes, Bob.
It's kind of funny to me that with transplant, you kind of talk about this in different studies. In pediatric oncology, we tend to all do the same thing. That's not for transplant. We hold on to a lot of things. Like our colleagues in the state next to us love CAMPAT. You know, on CAMPAT, outside of picture still, I don't see a whole lot of it. What do you think about it?
And I think you're hitting on a point is I think one thing that I've talked about too before, so much of it is the devil you know, right? Like we used a lot of ABBA in Atlanta. We were running a clinical trial. We knew our risks. We really knew it in and out, and it could be successful in that setting. I think our colleagues at Johns Hopkins, like they're very comfortable with PT-Cy for everything that they do. Other centers are really comfortable with doing cord transplants and others aren't. So I think so much of it is the devil you know. And so I think there are definitely reports out there having success with CAMPATH. I don't tend to use a lot of CAMPATH because I just don't have the experience, and I think I wouldn't be probably doing it right because there's an art to it. And so I think that's probably part of it is, yeah. Yeah, Corey.
Yeah, so with the alpha beta depleted T-cell grafts with a high viral infection rate on that study, was it, were they like severe viral, or were they like mortality, I guess, was it significant from infection?
No, I didn't think so. The problem with these studies, and we ran into this with our ABBA study, is the more data you publish, the more people pick apart. Right? If you look at the PT-Cy study, they give you nothing. They don't give you CD4 counts. They don't give you viral infections hardly ever. So the data looks beautiful because they don't but if you start showing that data, you're going to be drawn to it. So what it does show is that your CD4 count at day 100 is lower with alpha beta. They weren't dying from these infections. The 10-year overall survival was 75%, which is pretty good for a transplant patient. And so I don't know if it's as problematic as it was initially maybe thought to be. All right, I think that's it. Thanks, John.
Okay, our next speaker is Dr. Naveen Pinto. Dr. Pinto is a professor at University of Colorado and an attending at Colorado Children's, and has strong ties to New Orleans. He was actually born here, which is kind of awesome, and he's been at CAGLA now for 3 years in a row. He and I did fellowship together, which for him was really tough. I mean, imagine doing fellowship with somebody with so much style. It was tough for him. But he managed to muggle through that and is now one of the country's experts on neuroblastoma, which he's going to talk about today.
He always has to rub in the style thing. It's so true, but it hurts every time I hear it. Okay, let's see here. Okay, great. So I'm going to try and do a rapid-fire overview of neuroblastoma and the landscape and essentially how we got to our current standards of care through the history of clinical trials. So this is a slide that I borrowed from Bob and my mentor from the University of Chicago, Sue Cohn, and really drew me to neuroblastoma was its really interesting clinical and biologic heterogeneity. On the far left of the screen, we have a child that had a large adrenal mass with a liver chock-a-block full of tumor. And based on what we knew of the age of presentation and the biology of the tumor, this patient was observed and had spontaneous regression of their tumor without any treatment. That's the formerly known 4S, or now known as MS stage of neuroblastoma. In the middle is a patient who had a very similar presentation, a very large infiltrative primary tumor, and some metastatic disease. But again, based on the age of presentation and the biology of the biopsied tumor, we knew that this patient only needed a whiff of chemotherapy. This patient received, I believe, 4 cycles of outpatient chemotherapy and did excellent and had residual tumor that was left in their body after 4 cycles, but we knew that that tumor would not pose any future threats. And then, what I'll focus on is high-risk neuroblastoma, which is the challenge. This is a patient who's photographed at presentation with the classic raccoon eye presentation of orbital metastatic disease and very ill with widespread metastatic disease. And despite a very aggressive kitchen sink approach, which I'll get into, still only about 50% of patients in this category survive. So this is just sort of general boards information. Neuroblastoma is the most common extracranial solid tumor, or the third most common tumor that we see in pediatrics behind ALL and brain tumors. I included this relatively busy slide, just that neuroblastoma can present in a variety of different ways, most commonly with abdominal swelling and pain. But it's one of the few tumors that also has paraneoplastic syndromes, which are very interesting. So patients can present with opsoclonus myoclonus ataxia syndrome, which is an autoimmune condition where we think that the B cells are trying to control the patient's tumor and cross-react with the patient's neurons. This can be a very challenging disease to treat. And we're just now starting to understand some of the biology. And then I've only seen this a couple of times. Most recently, a month ago, a patient with intractable diarrhea as their tumor secretes a vasoactive intestinal peptide. The staging system used to be a straightforward 1 through 4 system with the 4S pattern thrown in for good measure. And we've simplified things now to either localized or L if it infiltrates and wraps around organs or blood vessels, it's L2. M is for metastatic, and MS is the old 4S pattern. We're also starting to understand the biology now of why this wide clinical behavior and spontaneous regression versus metastatic disease that either behaves itself or doesn't. And really it boils down to telomere maintenance. So high-risk tumors tend to have a telomere maintenance mechanism, a mechanism to maintain the length of their telomeres through subsequent cell divisions. Normal cells do not have that, and so non-high-risk tumors do not have a telomere maintenance mechanism, and as they divide, their telomeres get shorter and shorter, and there's a critical point when your telomeres are short enough that the cells either senesce or die. And so high-risk tumors are sort of immortal because they have a way to maintain the length of their telomeres and therefore are very resistant to death. We also know that very rarely neuroblastoma can run in families. There are really two major categories where this happens, both syndromic and non-syndromic family history. So non-syndromic, those patients don't have any other symptoms besides a history of neuroblastoma. These families tend to have ALK mutations. This was shown by Yael Moshe at CHOP in the mid-2000s. Then the syndromic form, which I didn't show here, is something called central congenital hypoventilation syndrome, also known as Ondine's curse. That is a germline mutation in FOX2B. These patients have, as the syndrome suggests, have hypoventilation, usually are trach vent dependent, and stay in the hospital for long periods of time, mostly due to their respiratory issues. So there's a whole host of prognostic markers that we have learned about in neuroblastoma, and I've highlighted really in red that we're still using features that we discovered in the 70s and 80s to risk stratify patients. And all of this other long list of genomic aberrations that we found subsequently haven't improved our power to prognosticate patients above and beyond what very astute clinicians learned almost 40 or 50 years ago. Again, another busy slide. This is taken from Meredith Irwin's paper in the JCO a couple of years ago, which really breaks down how we risk stratify neuroblastoma patients. So it's unfortunately too small to show here. I apologize, but we take the patient's stage, their age. The middle portion here are essentially genomic risk factors like MICAN amplification, and out spits your risk group, and therefore most people, like Bob mentioned, sort of follow the COG approach to treating these tumors. So about half of patients with newly diagnosed neuroblastoma have high-risk disease, and you can see the breakdown of the other risk groups. And again, this is sort of the really stark differences in survival. So low-risk patients essentially need no therapy, either surgery alone or observation. Intermediate risk patients usually receive very low-intensity outpatient chemotherapy, 2 to 8 cycles, and have excellent outcomes with very de-intensified therapy. And this is an old slide now taken from 2001, so the high-risk survival is skewed downwards to what it is today, but does sort of illustrate the stark contrast in outcomes between these groups. Luckily, we're a little bit closer to the high 50s now, so this curve should really be drawn here. So really, the goal of neuroblastoma treatment is to tailor therapy according to the patient's risk. And I'm going to run through several clinical trials that have been done over the last 30 years, mostly through the Children's Oncology Group and its predecessors, to help the audience understand how we got to where we're at today. The first is influenced our understanding of low-risk neuroblastoma. So this was a POG study, 9641, done in the late 1990s and early 2000s. Essentially, we used to treat all neuroblastoma patients the same with relatively intensive chemotherapy, and started to learn that some of these clinical and biologic risk factors may predict good versus bad actors. And so, based on our understanding of the biology at the time, we said that patients with localized tumors who were asymptomatic and didn't have any of the adverse biologic features like MICAN amplification may be successfully treated with surgery alone. And so asymptomatic patients had that, and symptomatic patients who had organ compression, spinal cord compression, severe pain, were treated with 2 or 4, up to 4 cycles of low-intensity chemotherapy to shrink the tumor, followed by a surgery. So these are the outcomes for that trial. As you can see, the overall survival is excellent. Close to 100% of patients survived with this approach. And the event-free survival, although it looks much lower, I'll just highlight that the graph starts at 60%. So over 90% of patients did not have their tumor progress or recur with this approach. So then to sort of further this approach, there was an observational study that told us that maybe even surgery was too intensive of a treatment for a subset of patients. And this was a study that had an initial intention, and we learned a different outcome. So the initial intention of a study was that we know that many neuroblastomas secrete HVA and VMA. These are catecholamine metabolites in the urine. And so people smart investigators said, well, can we newborn screen babies for neuroblastoma by testing their urine? And could we detect localized tumors before they metastasize and therefore prevent patients from developing high-risk neuroblastoma? So these were newborn screening programs that happened in Japan and French Canada, where in both subsets, they essentially doubled the rate of neuroblastoma in those communities, but there was no decrease in incidence of mortality. And that all of the tumors that came up on screening and then were resected had favorable biology, didn't have MYC amplification, didn't have any of the adverse biologic features. And so the conclusion of this screening study was that tumors diagnosed in infants are unlikely to progress to high-risk neuroblastoma. And many of these, because we doubled the rate of incidence, were clinically undetectable and therefore likely spontaneously regress. So this shifted our understanding of low-risk neuroblastoma and that patients may be successfully observed without any interventions at all. So in the early days of the Children's Oncology Group, AMBL00P2 performed in the early 2000s, took patients less than 6 months of age with a small localized tumor limited to the adrenal gland and did nothing. They tested positive for catecholamine metabolite increase. They had a tumor in a location that was most likely to be a neuroblastoma, but they didn't get a biopsy. They didn't have any intervention. And this is the result of that study, looking at resection-free survival. So what was your probability of staying on the study without needing to go to surgery? And over 80% of patients were successfully observed in this cohort. Now, and if you really cut the data, there were many patients that the actual resection-free survival is probably higher than this because many physicians got nervous in the early days of this, and many parents got nervous. And subsequent studies have shown it's probably in the mid-90s of patients that can be successfully observed in this cohort. The COG had a follow-up study which broadened the enrollment criteria for this, and we're anxiously awaiting those results. But we just learned, I was involved in this study and just learned that the last patient finished their observation period, so we can start analyzing the data very soon. And we anticipate that even in a wider cohort of young patients with localized tumors that they can be successfully observed. So we'll jump to intermediate risk. Again, this is trying to tailor the amount of treatment needed to advance a good outcome. And the first study of this was a Children's Cancer Group, or CCG, study of infants and children with intermediate risk neuroblastoma, again, performed in the late 90s. This tailored the amount of chemotherapy based on the patient's tumor biology. These were all MYC non-amplified tumors by definition, but patients with favorable histology and hyperdiploid tumors got less chemotherapy than those with unfavorable histology or diploid tumors. So 4 versus 8 cycles of chemotherapy dictated by the tumor's biology. And again, another excellent survival curve from that approach. Over 90% of patients did not experience a relapse or progression, and almost 100% of patients survived with this approach. In fact, as I dug into the data, there were at least one patient that died of a non-neuroblastoma cause on this curve that died in an automobile accident. And so the curves are pretty darn close to 100%. So that led to the predecessor intermediate risk study where, again, we used as much biology as we knew possible for neuroblastoma, things like ploidy, histology, and any segmental chromosomal aberrations to really dictate the amount of therapy. A very busy slide here just showing the sort of choose your own adventure nature of this non-high-risk study, but giving patients as few as 2 cycles of chemotherapy and as many as 8, depending on their tumor biology. And again, you can see here that almost universally these patients did quite well with overall survival is well above 80%. The patients at the lowest curve are those with the most aggressive types of neuroblastoma metastatic disease with unfavorable genomic features. Again, this curve is a little worrisome, and again, we're trying to address ways to better treat these patients in future clinical trials. So I'll dive into high-risk neuroblastoma because this really exists as the challenge. Our current treatment overview is really broken down into 3 major phases. Induction chemotherapy, where we give traditional cytotoxic chemotherapies, an attempt to surgically resect the primary tumor, and a collection of the patient's own peripheral blood stem cells to be used in the next phase of therapy, consolidation, where at least in the Children's Oncology Group, the standard of care has emerged to do 2 tandem cycles of high-dose chemotherapy followed by autologous stem cell infusions. Radiation therapy is used to the primary tumor and any metastatic sites that persist. And then neuroblastoma was one of the first pediatric tumors to use immunotherapy to achieve better outcomes, and I'll show some of that data. So again, we've made progress. The curve that I showed comparing non-high-risk and high-risk outcomes, again, was showing outcomes sort of in the 40% from the late 90s, early 2000s. And our curves now are getting into close to the 60% range for 3-year event-free survival. So not ideal, and there's a lot of work to do, but these gradual intensifications of therapy on cooperative group studies have led to improvements in outcome. I'll highlight my colleague Julie Park from Seattle Children's, now the Director of Oncology at St. Jude, who led one of the most seminal high-risk neuroblastoma studies that informed standard of care, and this was ANBL 0532, a study that randomized patients who had responded to induction chemotherapy, 6 cycles of induction, to get either 1 autologous transplant with a CEM conditioning regimen or tandem transplant with 2 cycles of high-intensity chemotherapy followed by an autologous stem cell infusion. All patients went on to get radiation therapy to their primary tumor, and there was a concurrent study that I'll highlight that was evaluating this novel immunotherapy, dinutuximab, with cytokines that patients could also enroll on. So Julie's data was presented at ASCO in 2016 and then published in JAMA the next year, and showed that there was a statistically significant reduction in relapse or 3-year event-free survival with tandem transplant. There was not a significant change in overall survival between single versus tandem, which is sort of the main critique, but this change in event-free survival did lead to many centers adopting tandem transplant as the standard of care. There were some subset analyses because immunotherapy wasn't routinely used for every single patient that was on Dr. Park's study that if you bisect the data further and look at patients who got tandem plus post-transplant dinutuximab, that there was a statistically significant difference in event-free and overall survival in those cohorts. Again, this is the data that led to dinutuximab being approved by the FDA. This was randomizing patients after completion of consolidation and radiation therapy to either get a differentiating agent, cis-retinoic acid or Accutane, with or without the anti-GD2 antibody, now known as dinutuximab. This was given with 2 different cytokines, either GM-CSF or IL-2, to stimulate an innate immune response. And the sort of proposed mechanisms of action of dinutuximab were that it both had complement-dependent cytotoxicity, that antibody-bound tumor cells would activate the complement cascade, leading to the membrane attack complex formation and tumor lysis. And there was also a cellular component that these antibody-tagged tumor cells would trigger NK cells to lyse these target cells, and that the proposed mechanism of IL-2 and GM-CSF was to increase numbers of these effector cells. So the results from that study, again, showed an improvement for those patients who got the anti-GD2 antibody. This is, again, event-free, not overall survival, but a pretty dramatic increase in event-free survival, which, again, led to really the first pediatric only approval of an immunotherapy. And again, this is still a drug that's really only used in neuroblastoma. So again, a whirlwind tour of data that has gotten us to tandem transplant, post-transplant dinutuximab being the standard of care for high-risk patients, and using patients' biology to dictate how much therapy, if any, in the non-high-risk setting. So these are just some bullets from the high-risk neuroblastoma studies I highlighted, that somewhat better outcomes are observed when consolidation is intensified with tandem transplant. I didn't show this data, but a question I get asked from a lot of parents when we're talking about giving back a patient with metastatic disease their own stem cells is, aren't you just giving back my child their neuroblastoma? And so there was a study where peripheral blood stem cells were purged of any residual neuroblastoma cells in an early COG study, and that did not show any impact on outcome. So we do not think that the neuroblastoma cells do well in the cryopreservation environment, and that very few neuroblastoma cells actually are circulating at the time of peripheral blood stem cell collection. We know that post-consolidation therapy with both Accutane and dinutuximab is effective, but all of these studies have essentially been adding more and more and more to high risk because our outcomes aren't great, and that we know that this intensification of therapy over time has led to significant toxicities, many late effects, and yet 50 to 60% of patients still relapse. So just wanted to highlight a few areas where we're going. This is a cartoon from a publication I was involved in, sort of highlighting some of the cellular pathways that are potential vulnerabilities in neuroblastoma. There are cell surface proteins like GD2, which is what dinutuximab targets, and L1-CAM that may be suitable targets for things like CAR T cells. The group in Rome at Bambino Gesù did a CAR T cell study for relapsed neuroblastoma patients targeting GD2, and in a very select group of patients with relatively low disease burden but relapsed disease, reported a 60-some% objective response rate to those CAR T cells. Theranostics are a hot topic in adult oncology like prostate cancer, and neuroblastoma was also one of the very first tumors to be treated with radio-labeled theranostics like MIBG. We have all sorts of cellular pathways, anti-angiogenic inhibitors, tyrosine kinase inhibitors that are also being evaluated. But I wanted to highlight MIBG therapy because that's a therapy that our center offers and isn't offered universally. So MIBG is used both in diagnostic. We do MIBG scans. This is a cartoon of norepinephrine, and you can see the similarities for MIBG, which is meta-iodobenzylguanidine, an iodine-labeled molecule that can be taken up by the norepinephrine transporter in neuroblastoma cells and helps us in diagnostic scans to look for sites of metastatic disease. This patient with relatively oligometastatic disease, meaning just localized tumors with a few sites of metastatic disease, and this patient with much more extensive disease throughout most of the bones and bone marrow. Administering I-131 MIBG as a theranostic is challenging in that it makes the patient radioactive. So the patient who gets a dose of MIBG therapy has to be in isolation. And with most of our neuroblastoma patients being toddler age, this can be very challenging. And so the patient is emitting relatively high doses of radiation from their body. And so we have to be very careful when giving this drug. We have to use a Geiger counter on our clothes and shoes as we enter and exit the room, track our radiation doses very diligently to ensure we're not exposed to radiation. And then this is just a picture of the drywall, beneath the drywall in the MIBG room, which is a lead-lined room. So these are lead bricks lining the room to prevent exposure to radiation therapy for those outside of the room. So MIBG therapy was very active, or at one of the most active agents we saw in relapse. About 30% of patients with relapsed neuroblastoma will respond to MIBG therapy. And based on that encouraging response, the COG ran a trial. I apologize for how busy it is, but essentially the question they were asking on this trial was, could MIBG therapy be incorporated into upfront treatment of high-risk neuroblastoma patients and improve outcomes? I don't have the results of that study, unfortunately. The study was closed about 3 years ago, and I have been told that the results will come in October of this year. So we'll soon learn whether MIBG therapy should be considered for everyone if it improves outcomes. Our current high-risk trial is looking at dinutuximab as an addition to induction chemotherapy. So I mentioned that dinutuximab given after transplant improves outcomes. There was some data generated by St. Jude that if you gave dinutuximab with induction chemotherapy, you improved your end induction responses, and that at least in the hands of St. Jude, the overall and 3-year event-free and overall survival were improved to other historical studies. So that generated a lot of enthusiasm, and we're now randomizing patients 1-to-1 to receive either our standard 5 cycles of induction with just chemotherapy alone, or chemotherapy plus dinutuximab. The study we want to sort of stratify patients by their known biology, like MYC-N, presence of metastatic disease, and so everyone gets a single cycle of standard cytotoxic chemotherapy, and then once all the biology information is back, we randomize patients and try and balance the randomized arms. Everyone then goes on to get tandem transplant and post-consolidation dinutuximab as is the standard. So we know that, again, we've intensified therapy to lead to these superior outcomes, and that definitely comes at a cost. Essentially, every organ in a neuroblastoma patient's body, should they survive, has been affected by the intensive treatment. The most obvious are ototoxicity or hearing loss induced by platinum compounds. But really, like I mentioned, every organ system seems to be affected. Endocrine dysfunction and infertility is another really prominent feature. This is a patient standing amongst her peers, who you can see is quite delayed in both her height and in her sexual maturation. And again, this is a publication from a colleague from the University of Chicago, Mark Applebaum, that showed that the rates of secondary malignancies, if you look by era, that in the most recent era, the graph of secondary malignancies seems to be escalating compared to historical controls, and that you could march this out, and that, 20 to 30 years from the current era, that we may see secondary malignancy rates as high as 5%. Relapse neuroblastoma, just very quickly. I'm over time, I apologize. Really, our current standard care is to use dinutuximab with chemotherapy. So this was a randomized study where patients got irinotecan and temozolomide and either temsirolimus, which was an mTOR inhibitor, which had some in vivo activity in model systems against neuroblastoma versus dinutuximab. And the results were pretty dramatic, that dinutuximab improved outcomes. So this has become our sort of de facto standard of care for relapse disease. Okay, I'm over time, so thank you very much. I'm happy to take questions or move on to the next talk. Bob. Yeah. Yeah. Yeah, this is an eternal debate in the field. I didn't have time to include this, but we're already working on the next phase 3 study in neuroblastoma, which I'm going to lead with Jenny Foster from Texas Children's. And that is actually based on this relapse data of chemoimmunotherapy being very active. We're actually going to randomize patients to chemoimmunotherapy consolidation, 6 cycles of reno, tem, dinutuximab, versus tandem transplant. So it's transplant-free approach, trying to mimic the MSK approach. I think MSK's data is very exciting, and they do treat many of their patients without transplant, but it's so personalized at the level of the patient that it's really hard to draw any conclusions about how to do that, in a wider cooperative setting. So this was our attempt to try and see if a transplant-free approach is feasible. Yeah.
Second question is, I may be making this up. I thought I recently read that there's a trial that's about to start using a p53 activator in neuroblastoma early phase. Is that at the advance? Have you seen that?
That is not coming through the NANT consortium. I mean, there's a lot of interest in p53 activators, and certainly patients who acquire p53 mutations or have them de novo have really bad outcomes. So I'm not sure.
I came across this activity for me, and I just saw that it's about to be trialed, I think.
Yeah.
For neuroblastoma, it's going to be the first pediatric drug. I don't remember though where.
Yeah, a lot of that work came out of Utah from Josh Schiffman. But I don't. So I'll have to get back to you. I'm not sure where that's. Yeah. Yeah, yeah. Okay, thank you, everyone. Appreciate it.
Okay. Our next speaker is going to be Kayla Thibodeau. Kayla is a clinical pharmacist extraordinaire who makes my daily life so much easier. She's going to be talking today about pharmacogenomics in pediatric cancer, something that she knows really well. She did a training at St. Jude's in pharmacogenomics for peds. Kayla.
Definitely gonna need mic down for me. All right. Awesome. Well, thank you very much for the kind introduction, and thank you everyone for showing up today for my talk about pharmacogenomics and pediatric oncology. Today my talk is mostly going to be just about the application of pharmacogenomics in this patient population, but I also wanted to bring to light some ways that you can possibly incorporate it into your clinical practice, as well as some future directions to look forward to. So I don't have any financial disclosures or conflicts of interest. So by a show of hands, who knows what pharmacogenomics is? Great, that's awesome. I'm so happy to see that. So just to get everybody on the same page, so pharmacogenomics, we can kind of split into two words, pharmaco referring to pharmacy or medicine, genomics referring to the genome or DNA. So it's really about how the genetic variation of a patient contributes to the variability in their response to medication. And pharmacogenomics really is just a branch of precision medicine, and it helps us to understand a little bit more about why there's variation in therapeutic response, as well as why some patients have more toxicities or adverse effects compared to others. So whether you have pharmacogenomics in your current practice or not, what's on this screen here is sort of a universal experience. So we have on the left a patient population. Let's say that they have the same diagnosis, they're going to receive this same little blue pill, they have the same dose and the same schedule of this medication. And then what we see is on the right that we don't have the same response among everyone. So there's those people in the green who have exactly what we want. They have the therapeutic response with very minimal toxicity or adverse effects. But then you'll also see on the other hand this yellow group who have no response to the therapy, or even the patients in red who have toxicity. So as you can see, this is not a one-size-fits-all approach to anyone, so we have to make it a little bit more personalized. And so why is this? Why do we have to do this? There's lots of things that impact how a patient responds to medication, and pharmacogenomics or genetics is not the only thing. So there's multiple pieces to this puzzle that have to be taken into consideration, like intrinsic factors, which we already are considering. So things like renal function and the patient's age and whether they are obese or not, all these things, as well as other external factors like diet and exercise, drug-drug interactions, smoking and alcohol consumption, their environment, whether they're actually taking the medication. All of these things come into play on whether a patient will respond to therapy. So there are two main methods of pharmacogenomic testing, one being reactive and the other preemptive. So I'll explain this to you a little bit, and I'm sure that we all kind of have a little bit of a mix of which one we practice with. So reactive you can think of as, okay, I'm contemplating prescribing a medication, or I am prescribing a medication, and now I'm gonna get pharmacogenomic testing. Sometimes it's even done in the retrospect. We give a medication to a patient, and they have a severe side effect, or they're not responding as you expect to, and then we get pharmacogenomic testing, which would then change their therapy. And so the way you can think about this is like a just-in-time approach versus preemptive is whenever you're collecting this information about pharmacogenomic test results before the patient ever needs the medication. And a lot of us are kind of on the more reactive side, but if you're doing panel-based testing, there is also a factor of preemptive as well. So this preemptive method is actually more of like a just-in-case method, so just in case you need it further down the line if a patient were to be prescribed clopidogrel or thiopurine, etc. And so there's actually a little bit more that goes in between distinguishing these two types of tests other than just the kind of sequence of ordering. So turnaround time, or the time in which you have the results available, is another thing to consider. So when you're doing a reactive test, you also have to think about the lag time of the time you're ordering to the time you get the results back, which could be several days to even a few weeks, versus when you're doing it preemptively, you'll have that information readily available at the time of prescribing. Also, prescriber knowledge is going to be important here too, because if you're doing it reactively, you have to know about the gene that you're going to order a test for, right, in order to order that test, versus if you have this information available preemptively, there can actually be decision support built into the EMRs and things that'll flag you whenever you actually order the medicine that says, hey, you have this result, why don't we try this dose or try a different therapy. Cost is another variation, although both can have possible panel-based testing. So typically whenever you're doing preemptive testing, you're getting a whole panel of pharmacogenomic results versus preemptive when you're usually ordering a single gene, although this will vary by institution. So yeah. And so another thing I wanted to also talk about is just how ongoing research is really just shaping everything in healthcare, but it's also really strengthening the clinical implementation of pharmacogenomics in our practices. So pharmacogenomics, like everything else, starts with discovery research. So we first start out with identifying drug-gene pairs or variant alleles that have an implication on a patient's response to a drug. Then we take that further and study the mechanism of why, what enzymes, what is the reason for this, and then eventually we'll take this and bring it into patient care and bring this pharmacogenomic information to the bedside. All right, so now we're just going to talk a little bit more specifically about pharmacogenomics in pediatric oncology, mostly just going through why it's important. So the first reason is because many drugs in pharmacogenomics and in pediatric oncology have the CPIC-guided drug-gene pairs, and every individual is actually likely to harbor some type of actionable variant if you were to do a full panel-based test. So if I was to actually provide a panel-based test to everybody in this room, 95% of you would have one result that would be considered what we call high risk or actionable, which just means that you'd have a result that maybe down the line, if you're prescribed a medicine, you would have to have a change in dose or a change in therapy. And then taking that further, you see on this chart here that there's even like a 31% of you that would have more than one. So you have two, and then another about 30% would have three or more, et cetera, et cetera. So it does make a big impact. And then also with our large and growing numbers of actionable drug gene pairs, there's just more research being done, more genetic variants, and these associations with medications being found. It's a very booming space, and so there's lots of opportunity further down the line as we gain more research. And so I wanted to bring up the idea of a poster gene for pediatric oncology. So a lot of the times when you hear about oncology and precision medicine or pharmacogenomics, one of the big poster genes that they talk about is DPYD and fluoropyrimidines. So 5-FU, capecitabine. But in pediatric oncology, we really rarely use 5-FU. It's not something that we use a whole lot. So I figured we'd kind of take a step back and think about one that would be good for us. And I think TPMT and NUD-T15 is definitely one that is most prevalent in the pediatric oncology space. And like we saw in previous presentations, ALL is our #1 malignancy in pediatrics. And then with that, thiopurines are like one of our mainstays of treatment for ALL, so it's very common. And then we experience this with patients all the time. There's just a varied response to therapy. There's lots of myelosuppression, low counts, delays in therapies, dose reductions that are seen very often. And another reason that I think this would be a good poster gene is because it is one of the very first pharmacogenomic relationships that we were actually able to identify. So it was actually one of the very first pharmacogenomic associations that was actually discovered. So mercaptopurine actually came to the market in the 1950s, and then we actually found the link between TPMT and thiopurine use almost 36 years later. And then from there, we were able to start incorporating single gene tests into our own clinical practice so that we can test patients and see if we have to make dose adjustments. And then from there, we gathered lots of data from patients and max tolerated doses to eventually develop our first CPIC guideline about TPMT genotypes and thiopurine dosing. NUD-T15 actually came back much later where we actually identified that one, and the link there was discovered in 2014, and then we then modified those CPIC guidelines in 2018. All right, but the timeline does not stop there. There's actually been even more evidence and data come out recently that's still shaping guidelines. So there was actually a study done in 2024 about the additive effects of TPMT and NUD-T15 on thiopurine toxicity in children with ALL across multi-ethnic populations. So this study was done in 2 segments. They first had a clinical segment in which they looked at over 1,700 patients who were genotyped for both TPMT and NUD-T15 and had received mercaptopurine at the standard dosing. And then they also looked at these patients and kind of compiled all of their genotype information and found that there was only 22 of those patients who possessed a TPMT and NUD-T15 intermediate metabolizer status. So before this study was done, and kind of the reason it was done, is because they were seeing in clinical practice that the dose recommendations for reduction for a patient with either a single gene of TPMT or NUD-T15 intermediate metabolizer or both was the same reduction. But they were seeing that these patients who had both intermediate metabolizer status actually needed even further dose reductions. And so the study was done, looked at these patients, and sure enough, their maximum tolerated doses were actually much lower than those who either had a single intermediate metabolizer status or they were normal. And so then they took this information and they brought it back to the lab, and they did it in mice models. So they genetically modified the mice to express either one or both of those intermediate metabolizer status, and saw a very similar thing in that they had earlier toxic death whenever they had both with the standard dose recommendation. So what this led to was a shift in our guidelines to now include new recommendations for patients who are compound intermediate metabolizers for both TPMT and NET-T15. And this is incorporated in both our CPIC guidelines, and this is actually a snippet from one of the most recent ALL protocols from COG. And so what I talked about before about how this is really strengthening and helping to implement pharmacogenomics into clinical practice, it also goes back around to this big feedback loop. So now we're learning more after it's been implemented into patient care and bringing it back to the benchmark, and then bringing it back to bedside again. So it's this lovely loop of ever-evolving information. So another reason why pharmacogenomics is important in pediatric oncology is because there is a high frequency of prescribing of medications that have a pharmacogenomic impact. Oh boy, all the stuff is glitchy here. But I'll kind of try to explain this to you. So this is kind of just showing the frequency of actionable, not frequency, the amount of actionable medication use, pharmacogenomically actionable medication use in a group of pediatric oncology patients over a 10-year span. So it was just identifying patients who received at least one of these drugs or drug classes on the right-hand side that you can't even see. But all this is showing is that there are hundreds and thousands of patients who are receiving these medications in this space. The top 5 that were shown were ondansetron, the NSAID class, thiopurines, of course, PPIs, and voriconazole. So there's lots of these medications that are commonly used in our pediatric oncology space, which makes it useful. And then lastly, and I think one of the most important reasons why it could be so useful is because there is this unique long-term benefit of our pediatric oncology survivors that we can continue forward this information. So childhood cancer survivors live decades beyond their treatment. So we are treating 4 and 5 and 6-year-olds, and sometimes even younger than that, sometimes a little older, but that just means that they have a lot of life left to live. So pharmacogenomics can be very useful in preventing and reducing long-term toxicities to their treatments, as well as kind of preventing those other things down the line. So unlike adults, these pediatric patients must carry these consequences of their chemotherapy exposure across an entire lifetime. Another thing that I used to say a lot whenever I was in the pharmacogenomics clinic is that genetic results are lifelong. So this is really great because that's not likely to change, with some exceptions that I'll talk about later. But a child's pharmacogenomic results can be used for future medications and medication use. And we know that these patients maybe will have some other chronic conditions associated that will have other medication use. So it's best to, if we can, do panel-based testing to help have all that data available in a preemptive manner. So, like I said, are they really lifelong results? There are some caveats and exceptions to this. So the DNA itself, of course, is lifelong, but the interpretation of the results may not be. So there's always new evidence, and even what we saw with TPMT and NET-T15, new guidelines or shifts in guideline recommendations. There's hundreds of drugs trying to come to the market every year, so new medications and possible other associations with genetics will also come forth, and then also reclassification of variants and even identification of new variants in a population can also make the interpretation different. Testing methods also matter significantly. So there's also newer technologies that come about where they have new variants that are tested that were maybe not previously detectable. So thinking about those things whenever you have a patient who presents to you with results that are from 10 years ago. The use of copy number variants, so there's still some testing out there that does not report copy number variants, which is actually very difficult to actually use in clinical practice because the results are very misleading. And then whole genome sequencing. So right now, a lot of our pharmacogenomic testing is done by SNP array testing, so just trying to detect whether a patient has a presence of a specific variant, whereas whole genome sequencing, you see everything. So if there's a stop codon that happens before you even translate the rest of the protein and things like that. So other things to consider about testing methods. And of course, there are instances in which a genetic makeup of a patient can change. One of those being allogeneic bone marrow transplants, and then liver transplants as well, also make an impact on that and the associated genetic chimerisms that can happen from that. So I also wanted to bring to light, if you have pharmacogenomics in your practice currently and are looking for ways to expand, or if you're even in the implementation stages and looking for places to bring pharmacogenomics forward, I think that survivorship clinics are actually a really great space for pharmacogenomics. So these visits really provide opportunities to educate and re-educate patients. So thinking about patients who maybe you've treated at the age of 12, and they're in survivorship clinic now at the age of 18, they may not have understood what these results meant at their initial time that you presented it to them, but now can take it forward and further be aware of it and bring it to their providers. And with the education piece, it's also very important to educate patients to show this to other providers outside of where you're practicing. So patients are likely to move around, go to college, move their life. So just making sure that they bring these results forward to other healthcare providers and institutions. Also, this helps to optimize dosing for medications and chronic conditions that these patients will have later on that maybe you're following up on for these patients. And also just creates a really good bridge to adult care. Okay, and now I'm going to talk about a little bit of future directions, things on the horizon in pediatric oncology and pharmacogenomics, kind of a mix of the two. So I'm sure you guys maybe have heard about irinotecan and UGT1A1 and considerations and dose reductions for that. So there's actually evidence review underway through CPIC, which is the Clinical Pharmacogenomics Implementation Consortium, to publish a guideline on this. What I did want to bring to light to this group is that I think that there's going to be a pretty big difference in the dose recommendations for modification for adults versus pediatrics. And this is simply because we dose things much differently in pediatrics for irinotecan specifically. So adults typically get like 125 to 180 per meter square in one single dose, versus in pediatrics we do over 5 days in little chunks of 50 milligrams per meter square, which I think also will make a difference on the toxicity overall. Another thing that was identified recently is the association between CEP72. There's a variant that they found there. This gene actually codes for microtubule formation in some kind of a way, and it's actually believed to have increased risk for vincristine-induced neuropathies. So there's ongoing trials right now that's actually clinically enrolling patients to receive a reduced versus a standard dose of vincristine for patients who have this variant specifically in ALL treatment, and seeing the difference between both efficacy, safety, and like the toxicity profile there. And then artificial intelligence, there was a whole talk about that this morning, but I think that this is going to be another avenue in which we see growth for pharmacogenomics as well. So there's possibility of combining multiple data streams within an electronic medical record, where we can take different patient factors that we talked about before in that puzzle piece section. So taking into account age and renal function and labs and pharmacogenomic results and giving us a precise dose to give to a patient. Also, it can be very important and helpful in helping us find more actionable drug-gene pairs for patients. So once we have the cloud of information of patients' full genome sequences available, it'll be able to kind of pull and see, well, with this patient and this patient both had to have dose reductions in this medication, maybe there's associated with this gene, and so on and so forth. I think that'll come much further down the line. But also can be very helpful in personalizing our survivorship care. So we already have a lot of these things built to help us see the cumulative doses that patients received of different chemotherapies within the EMR. But maybe this can go even further and incorporate other data points as well. Key takeaways, there was stuff there, I promise. So now you can just fill it in with your own mind of what you took away from this presentation. But it was a pleasure speaking with all of you. I really appreciate it, and I'm happy to take any questions that you guys might have. Yes.
So in your workplace, who's your favorite doctor? Me or Dr. Matthew?
Okay.
Just kidding. So in your experience did you want to answer?
No, I don't. I'll plead the fifth.
In your experience with like different payers, insurances, have you run across like some insurances that won't cover the panel, like the one on
I haven't experienced it myself. I know we have some pharmacogenomic experts in the room at our institution who probably play more into the payer role, and I know that we have some laws in the state of Louisiana as well that help to make this more accessible and affordable for patients as well. So.
I find it funny that the whole panel that we're sending now is cheaper than the individual drug testing.
Yes.
It makes no sense to me, but so with the standard.
You get more bang for your buck that way.
And the one for Kristen
Mhm.
comes on it? Does he-
Not yet. No.
But did y'all want to mention about that?
Yeah, sure, we can absolutely talk about that. So I will say that we do have legislation on the books about biomarker testing in the state of Louisiana, which was a CAGLA initiative, right? So thank Chad Johnson for training leadership there. The payer space has always been a challenge. We do see it, however, evolving. We know that there are multiple, both Medicare and Medicaid plans will pay for zero out-of-pocket for patients for panel-based testing. The commercial space varies widely, and can often, with prior authorization and that sort of thing, we can usually get it.
So we should, do the pre-auth before draw part, running it fast.
Do you guys happen to know what the cost of a panel is these days, cash price?
Cash is $350.
$350.
But I can tell you, at least like with our panel-based testing, all of the billing goes through our lab, and they will automatically enroll patients in financial assistance plans. So if they have a really high copay, if it's not covered by their private insurer, they'll reach out to patients, and they're typically able to get it down between around $100. Yes, our experience, so we have how many patients tested now for our, and they're over 6,000 or 7,000 patients with an Oshri who have results. And if you take out the patients with zero copay, so all of your government insurers or zero out of pocket, on average, our experience is around $110 to $120 per patient.
I guess along those lines, how would you counsel a loved one? Like your data, about 95% of us have a high tier variant. Like, do you know your own pharmacogenome? Do you?
I do. Yes.
And your parent,
Yeah, so that's a really great question, and I had a lot of experience. So at St. Jude, they actually had just, whenever I was there, had just started a pharmacogenomics clinic where the sole purpose of it was to educate patients and families on pharmacogenomics results. So a lot of these don't really have like major involvement where we have to call in like genetic counselors, but of course there are some instances in which we did. But it's just about kind of bringing it to the basics and talking to them and, making it simple and making it easy to understand, as well as kind of just sharing the need to know, right? So we're not going to go and explain every single variant, like you have this allele and this allele. We kind of explain it as a whole picture. Like you have normal results here, but here we found that maybe for this medication, you'll need a dose reduction or a dose increase, so. Yes?
A follow-up on that. Will we ever get to the stage where when a child is born, you do pharmacogenomics like a panel, so that for the rest of the life, the child knows what it
I think that's definitely on the horizon, and I think it'll go even further than that, and we'll just have their whole genome on day 2 after they're born from a heel stick or something like that. So I think that there's going to be lots of opportunity to have genetic information available earlier on in life to where it can be very useful and clinically utilizable
probably
future in life.
happen even before the child is born. Probably the parents want it done.
Yeah, even that, exactly. Absolutely, yes. Yeah, I think when it comes to being a pharmacist in the pharmacogenomic space, and especially in the implementation process, that is like the number one thing you have to look at, because you have to think about how this is going to impact the patient. You want to have the most up-to-date information, as well as making sure you're capturing all of the pharmacogenes that are going to be useful, that we have data for, and then making sure that those are testing everything that we need appropriately. So there's a huge comparison in all of these different panels to make sure all of those things. But it's definitely one of the most important things in the implementation process for sure. All right, thank you all very much.
You just made more work for yourself, by the way.
Oh no.
We're going to start integrating that into our survivor clinic. Okay, our last talk. These have been really great talks, by the way. Our last talk is going to be by Dr. Srinivasan Vijay Kumar. Dr. Vijay Kumar, another University of Chicago person in the house. Wow, that's awesome. And he's going to be talking about osteosarcoma and precision radiotherapy. Dr. Kumar.
That's difficult to follow after 3 great talks. I don't know. Maybe I should just walk away. How do I get to the... I don't see that. Is this the one?
They had them all open here, so
Here.
if I can.
Oh, this is my... Thank you.
Yeah.
Thank you. You all hear me? Okay. So I mean it, 3 great talks, okay? But I will try. It's going to be actually more of a, I'm using a case report to go to a space where some new breakthroughs could happen in osteosarcoma. And also, you know, radio immunomodulation. And I'm glad there are so many experts from hearing those talks who probably are, like leaps and bounds better than me. And we can put our heads together to do something better, okay? So these are all my colleagues. I was at the University of Mississippi Medical Center for 17 years. That was a great team. It was really an interdisciplinary care, and I want to thank all of them, and the patient and the family. So, you all know that great progress in outcomes has been made, achieved over the 50 years, limb sparing, use of neoadjuvant chemotherapy, and organ preservation, and whatnot. Overall survival, but there is nothing that has really improved in the past 20, 30 years. So that's kind of sad. And the outcomes have plateaued. The important poor prognostic factors are large tumors, less than 30% necrosis at neoadjuvant chemotherapy, metastatic disease, a short disease-free survival, and also local recurrence. Those are very important aspects. So the historical inflection point was 1970s, early 1980s. Landmark approach, you don't need any more amputation. Just imagine young adults and adolescents and little older children having to end up with amputation. That was, I've included some very remarkable landmark papers at the bottom. So the second one, of course, was as I said, limb salvage versus amputation giving equally good results. But look at the overall survival at that time, 55% overall. And that had improved over the next 20 years. And then this was an European study where they showed that you don't need, multiple agents, but we give 3 agents as a neoadjuvant standard in the United States now. And the rule of thumb is, you need more than 90% necrosis index to have good prognosis. And this was again shown in the SEER data at the population level that between 1984 and 2000, actually since late 1980s, the survival hasn't really moved up. Modern era summary plateau since this was published in 2021. Again, the same point. Despite use of some of the immunomodulatory agents and concepts. So metastatic disease, as I said, is bad. So about 10 to 15% present with metastatic disease, and lung mets are really bad, and that's a common involvement. And overall, it's like 60 to 70% if it is localized survival versus 20 to 30% with metastatic disease. So again, this is, as I said, 70 versus 30, 60 versus 20, that's the range, So this is 2025. Again, SEER data, age 5 to 29, extremity sarcomas, including neoadjuvant use. Interestingly, in this particular study, neoadjuvant didn't make a difference, but that hasn't yet been confirmed by an independent study. As I said, this is SEER, and when you have a SEER data, you need more robust data before we change our practice. That's at least my opinion, who doesn't actually give chemotherapy. So, yeah. So, relapse is persistently poor prognosis as a systematic review. So that's an important point. So there are about 5, 6 very important poor prognostic factor. The reason I went through all these poor prognostic factors for 2 reasons. One, this is the group we need to do new innovations. 2, my patient I'm going to present had most of them. And the first diagnosis was made in 2016 and still alive. So that's I'm a teaser. This is the teaser here, okay? So recap, significant improvements were made. I mean, we did good, but we are not improving it, okay? Almost more than quarter of a century. So what are bad things? Initial metastatic disease, less than 90% necrosis with neoadjuvant chemotherapy, locally recurrent tumor, large tumor, short interval time between first surgery and first recurrence, local or metastatic. And what I didn't show any data is axial and pelvic disease, because it's so difficult to operate and get every cell out. So we need some out-of-the-box innovation. Let's be that blue jet going away in innovation. So I will show you this extraordinary case. What are the clinical strategies and tactics? And it was remarkable because there are so many. You saw that collage of my colleagues. It was a great collaborative effort. I actually was Johnny-come-lately in the care. So it was a 24-year-old Hispanic male working for a major industry, showed up with a left elbow mass, and he had a biopsy, and it showed out to be telangiectatic variant of the left ulna. And this is a quick timeline from July 2016, and then he had the neoadjuvant chemo. Can you see the? Yeah, you all see this? Oh, you don't. Okay. So then he had neoadjuvant. He didn't have any good response at all. I'll show the pathological slide. Then he was he's a smart guy. He said, I didn't have any chemo response. Why do you want to give me the same chemo and get me into toxicity? He said no. Within 3 months, he had lung mets. And we said, let's give chemo. I used to go to all the PETs. I treated the PETs with radiotherapy. I had a name by my pediatric oncology group. Here comes the non-radiation oncologist. Because I would resist to give radiotherapy with all means. Because my first training started in 1979. And I know what damage we can do. That doesn't mean we don't use it. And I'm so glad the techniques of radiation therapy have improved leaps and bounds. This morning there are 2 extremely good presentations. How we are able to give a high quality life with good results by using a judicious use of radiotherapy is important. That's one of the lessons from this, hopefully from. And then after a year at PET CT, it was spreading more. And then our thoracic surgeon, nice bilateral, 13 lesions were removed. Okay, did good. Still said no chemo. Then he had bilateral adrenal tumors, and he had them removed. And then by the time cabozantinib results have started coming out, he agreed for that, no chemo. And then I did well, and then he had a right adrenal ex-tumor bed recurrence at the crevices of where the diaphragm and the vertebral body meet and the liver is. I'll show the pictures. And then what we did, that's when I was called in by my surgical oncology colleague. So we treated with SBRT techniques and gave SABR doses, 800 times 5, big doses, 3 cm, with all the tricks. We did the image fusion with PET. We made him a whole body cast so that his breathing is, and then we did treat him with breath hold so that it stops, and we use the respiratory, And I worked very closely with Shannon, our surgical oncologist. Usually surgeons wait for 6 weeks. I told Shannon, we need to operate at 4th week, because if you wait for 6 weeks, there will be too much fibrosis. I know you may not like it, let's do it. It turned out to be about 5 weeks. So I scrubbed in. We also got consent before treatment for IVO-RT. We had IVO-RT capability at that time. We did breast IVO-RTs. So I scrubbed in. He was standing operating on the right side of the patient. I'm just here. Then he says, turns, Vijay, what did you do? I was like nervous. Oh my God, I screwed up something. He said, it's liquid, man. I'll show the pathology. That was, well, we wanted it to be that way, okay? Because osteosarcoma is considered radioresistant. But I had worked at University of Chicago, and I worked in Dr. Bexabaum's lab. So we had all these curves. If you give big enough dose, we beat that curve. kill them. So that was the whole idea, and to operate quick enough. And then I gave IVRT to the tumor bed, and then we continued. So that's kind of this table, because busy table I explained. So I won't go over the details of that. The latest 2 weeks ago, he has a left adrenal tumor bed recurrence. Not in the right side, left. I have theory on it, but it's one case. You can't make.
Can you go back one slide?
Yeah. Yeah. Okay. So this was the original plain films, big one. Here is the MRI. I'll go through them fast. This is the original biopsy, osteosarcoma. So we did the metastatic workup, no mets, 2 cycles of MAP, and then he had surgery in November. This is the response to neoadjuvant chemotherapy, not much. And then within 3 months, he had lung mets, as I said. Here are the lung mets lesions with 2 different ways. He refused chemo. This was a year after all those bilateral lung lesions in PET-CT. And then this is a lung pathology. I'm showing this pathology slide for a specific purpose. You will see it soon. And then this was August. He continued on, we started him on cabazantinib, and here he recurred bilateral adrenals. No, we haven't started it. This is when we started here, bilateral adrenals. Then we wanted to shrink it, and when we did that, it shrank to some extent, partial response. Then we took that out. That's when my friend, surgical oncologist, got involved. So we had orthopedic oncologists, thoracic oncologists, then surgical oncologists, of course pediatric oncology, and then my medical physicist, radon, you just name it, and medical, although he was adult, he was treated actually by PDONC people. And then this is the adrenal. And then he recurred, look at that corner out there. This is what here is the liver. For my surgical oncologist to go out and take it out would have been extremely difficult, would have left a lot of microscopic disease. So we went with pre-op, and we did, this is the microscopic. So what we did, as I said, it was liquefied, and after that, we looked at the path. They're not any tumor cells. And the hemorrhage and hyalinization and all that. So the recent March, they are discussing how to treat him now. So that's kind of single case. So what's my hypothesis? He shouldn't be living. Although, I should say, his tumor did behave a little different. After lung mets, initially, he was almost 1 year. It did spread, but not like boom spread. You know what I mean? So, and after lung, he took another 2 years, although before it became enough. So it does seem to behave differently. But what are the factors that helped him, to me? Extremely interdisciplinary. I'm saying interdisciplinary, it's not just multidisciplinary. because we got all our medical physics and who else not involved, okay? And willingness to do metastasectomy, 13 lesions removed, and also listen to the patient. I mean, he didn't want chemo, so we kind of dialed up the surveillance sequence, and he was working, good quality of life all through. And the only symptom he got was diarrhea for cabazantinib, and we went from 40 milligram to 30 milligram. That kind of helped. And then using new target agent as soon, within few months after it was FDA approved, actually.
Was he, sorry, one quick question. Was
Yeah.
he symptomatic, like from adrenal insufficiency standpoint?
No, we started giving him.
He was, yeah.
Yes,
physiologic
immediately,
and
yeah.
fine.
Yeah, we gave cortisone and all.
Yeah.
See, that's why I'm saying endocrinologists were involved.
Right.
Yeah. I didn't go. We just submitted the paper. I was waiting long enough. I didn't want to. I mean, I put everything together 6 years ago because I would forget. I put all the figures and everything, but I didn't want to get it out premature. So traditionally, osteosarcoma cells are considered real. It's used usually in the mandible after they do surgery and the pelvis and things like that, okay? And the doses, usually the way we treat, you all know that in radiation angle, 2 gray fraction because it gets to, am I okay with time? Yeah. You know, normal tissue toxicity, but with limited dose, we can, you know, with the SBRT and all the things we are able to do. I remember, in my first training in India, we had a machine called Janus. Janus is the Greek god of 2 heads. So they had something called cobalt machines. You know the cobalt machine. I mean, in those days, the cobalt sources were very expensive. So what we had, it was actually designed by one of the radiation oncologists at Harvard University. He traveled all over the country, all world and helped. So, and once there are 2 identical twin rooms where we can treat the patient. It was so busy, right, in India population. So one set of technology will set one patient to treat. Meanwhile, somebody will be ready, and they'll pull. This source will go from here to there. That's why it's called Janus. Then you treat that. Meanwhile, another patient would be ready, so that the efficiency was good. But you should see, I mean, in cervix patient, because it didn't have enough penetration like modern machines. If you treat cervix patient, we treat it from in front and behind. The machine doesn't go behind, so you have to treat the lady with cervix cancer, treat like this, and they have to turn over and treat. You feel the abdomen is like carpet. Now, you don't see that. I mean, we used to see all that, right? I know how bad radiation can be. Anyway, so we did all this, as I said, 4D CT simulation, rigid immobilization, image fusion, breath holding, whatnot. Small volume. See, I just compare here the adrenal gland with all the tumors versus dead cells. Same thing, same kind of slide. So, and as I said, you know, this quick, there's a lot of beautiful history about cabazantinib. And anyway, I won't go through this, I think kind of late. So, the potential benefits were hypothesized by between 2016 and 2018. We started using it 2020. And then, see, this is what I want. A RAD is not a RAD is not a RAD. Because it's not the machine. I call it, it's not the hardware, you stupid, it's the software. in the software, I mean, I used to, I tell my resident, double meaning. One is, the softwares have improved so that we can do a lot of very neat things, but it's also software of how the physicians and medical physicists and dosimetrists work together. I mean, it's like, it's a complicated, the chance to make an error is extremely high. The quality assurance, I tell you, has to be extreme. Anyway, so concurrent and post radiotherapy use of radiobiological agents and what I call radio immunomodulation. Why am I saying that? This was a paper I published, and I think I'm the only first one to coin the word radiobiotherapy. See, we all use chemoradiotherapy, but now we use all kinds of biological agents. But sometimes they are good. For example, cabozantinib has recall phenomena. In other words, figure it's just like azithromycin. You wait for some more time, you can get a recall phenomenon. So the good news is they seem to be working together. The bad news is you have to watch out for things. That's why we need a new biological concept where we have to think very carefully when we give targeted agents, chemo and radio all together. We have to, this is, everyone, I mean, you know, especially radiation oncologists have to know about targeted agents. So how can we do some phase 1-2 study? This is where I want to pick your brain. I'm going to throw some ideas, but you guys tell me whether it's possible, because you are all in POG, and you know, and COG, I'm using old word, I'm an old man. Okay, ablative radiotherapy as an in situ vaccine. What I mean, see, I give the example of sharpshooter versus throwing a grenade. Okay, so when you give ablative doses, it's like taking a small area of tumor and you are blasting it. So you produce new antigens and the body's immune system suddenly wakes up. Oh my God, these are real foreign DNAs. And I mean, there are data, I'm not making it up. So I think that kind of thing can happen when you give immunomodulation agent, a targeted agent, and very high dose radiotherapy to a small volume and explodes. So the shift from mutation-centric targeting in biology to biology-aligned strategies that include smart use of radiotherapy as another drug. See, this is not radiotherapy of old times. This is radiotherapy where we all work together to use as a new way of another additional drug. The exploiting the consequence of genomic instability rather than single drivers. So genomic instability can be smartly introduced by smart radiotherapy. So that's what I mean by radiobiotherapy. Beyond systemic drugs alone, rethinking precision as an integrated ecosystem level control, because we popularized a word called precision population medicine. I'll show it in a second, okay? Because precision medicine is a lot more than genomic medicine. We often forget that. So locally recurrent osteosarcoma is where we can do phase 1-2 study, because there isn't much we can do. So you take those local recurrence, do chemo and SCABR and targeted agent, and then do the surgery, because that potentially can start the immune system to wake up and hopefully can improve the local control and distant mets. That's my hypothesis, 1, okay? Hypothesis 2, take metastatic, you have, let's say that we have 20 lesions. You take the big ones and you don't even have to treat the easily accessible one, away from heart, away from spinal cord. I mean, you know, we know how to do it. and then give them ablative doses. And then give the regular drugs, but use it as a immunomodulating extra drug. That's second hypothesis. And as I said, I already talked about locally recurrent. And then huge tumors, like my patient. We could have just, he was going to have amputation anyway, but you give a high dose, it's going to come out to a core of the tumor, let those new antigens go in, and that could have acted. What do we have to lose? That's another phase 1/2 study. So this is what we published this. What we meant by that, precision population medicine, is more than, I know it's very difficult to see. See, precision medicine to me is the right treatment at the right time for the right patient. It's not the right drug at the right time for the right patient. That's what we, most of the time we think. And that involves, this morning we heard about context by the general. The context is clinical practice, health organization, system context, legislation. This is a good meeting to talk about COGLA. I mean, all these things have to be considered. And to me, precision population medicine that will perfectly apply to Louisiana. So this is a figure we thought about where genomic medicine is important. EHR and related tools are important. Big data are important. This was published 7 years ago. But you also have all the other components so that we actually have a precision population medicine in our head. So I'm not going to read this paragraph. I just inserted this slide after I heard the 2 keynote speeches this morning. Because, see, there are some of the words that they used are very important here. Those are, see, genomic medicine, big data, EHR, telemedicine, smartphone, wearables. Not only that, interventions, but these should be in a manner that benefits from more inclusive definition, including lawmakers and academic places. Because that's how we move the ball forwards. I'll stop there. I'll take questions. Summary. Victory is for the brave. Victory is for the innovators. Victory is for those who learn from their previous life experience, like this case report. Team science is better than solo science. Interdisciplinary collaboration are what is likely to succeed. We can learn something new from a remarkable young man who survived many hours due to all of the above. Thank you very much. Yes, sir.